Good morning, everyone. I'd like to welcome you all, ask you to take your seats so we can get started with today's event. For everyone here, welcome to Washington and welcome to today's public meeting supported by the Duke-Margolis Center for Health Policy at Duke University on exploring opportunities to reform antimicrobial payment and post-market incentives. I'm Mark McClellan, the director of the Duke-Margolis Center. I also want to provide a thanks to the Wellcome Trust for their support for our efforts and so many others related to the global health challenge of antimicrobial resistance. We're pleased to see all of you here today, those of you who are joining us online, for what we know will be an interesting and productive day of discussion. Antimicrobial resistance is a serious and growing global health threat. And the need to provide better incentives for innovative treatments in this area has been an ongoing and similarly growing issue of national and global concern. This meeting is part of our larger research effort to explore innovative payment reforms, innovative models for new antimicrobials, and innovative payment models more generally in public and private programs in the United States and globally. Before we get started today, just a few housekeeping notes. At several points during the day, we're going to invite groups of speakers and panelists to provide remarks, have discussions about antimicrobial payment reform and other market incentives, other things affecting the antimicrobial ecosystem. To help keep us on track, we've got members of our team seated in the front, and they're going to provide the speakers and panelists with time prompts during the day. So for those of you who are speakers, say hi to Elizabeth and team up here. Keep an eye on them. Additionally, at the end of each session, we're going to ask people in the room to participate in some moderated discussion. So if you would like to make a comment during this part of the session, we've got microphones set up at a couple of places in the room. We ask that you use the microphones to make sure everybody here can hear, and also make sure that our online participants on the webcast can hear what's going on. In addition to the webcast taking place now, a recording of this meeting is going to be available on our website after the event as well. So we hope those of you who can't join us live also will be able to take advantage of that. If you are joining us on the webcast today, first of all, welcome. And second, if you'd like to ask a question or make a comment, it can go to AMR-incentives at duke.edu. AMR.incentives, I should say, at duke.edu. AMR.incentives at duke.edu. And we'll try to get your question or comment into the discussion. We also would like to encourage everyone to tweet today, hashtag AMR Incentives. You can also tag our account at Duke Margolis, so hashtag AMR Incentives for tweeting and at Duke Margolis for tagging. And we hope that will bring some more people in to join the conversation online. We have a couple of sessions this morning, and then we're going to break for lunch from 1 to 1:45. Lunch is on your own. You can bring back food here too. There are a number of good restaurants in the area. I personally like the foodie food trucks located right outside. And then we're also going to have a break between sessions 3 and 4 from 3 to 3:15. In the meantime, there's coffee and water outside in the hallway. So that's a little bit of context setting. I'd like to get started with an overview of some of the issues and goals for today. I think as most people in this room know, looking around the room, probably little disagreement with the statement on this page. Antimicrobial resistance is an increasingly significant global health threat. As you know, the numbers on resistance are getting worse, with a number of U.S. and global studies finding that the effectiveness of available antibiotics is falling, and according to the Centers for Disease Control and Prevention, nearly 3 million Americans had infections in recent years, resistant infections in recent years, over 35,000 deaths annually as a result. If you include the impact of Clostridium difficile, which is an opportunistic infection that often occurs as a result of antibiotic use, the numbers are even larger. We'll talk more about these numbers and trends in the next session. And this issue of rising resistance is by no means isolated to the U.S., with more severe patterns of resistance occurring in many other parts of the world. And at the same time, the available antibiotics to address this challenge are becoming increasingly strained, with the return on investment for antibiotics being low for a number of reasons. Every treatment faces development cost and sometimes payment models that don't fit well, but they're particularly challenging in the area of antibiotics, with challenges of treatments often being approved based on non-inferiority studies. You don't want to subject people who have serious infections to treatment that is at least a standard of care. So at initial approval, the evidence on differential effectiveness may be limited. Often antibiotics need to be used in patients who are quite sick, and we don't have rapidly available, very reliable diagnostics to identify exactly what organism is causing the infection and what its resistance profile would be, so making it hard to target these treatments even when they're available. Payment mechanisms are generally restrictive. We'll talk more about this in a few minutes and throughout the day. On top of that, this is a case where, if ever you didn't want to design a system with volume-based payments, this is probably it. The whole goal of having priority antibiotics available when they're needed is to make sure they're used and preserved when they're needed. So stewardship programs are a critical part of effective antimicrobial resistance management, but good stewardship is going to limit the payments for novel antibiotics that are reimbursed based on their volume of use. And finally, this is an area, because it involved infectious diseases and potential contagion impacts and other impacts on the rest of the population, this is a case where many of the benefits of an antibiotic, especially for a resistant organism, don't accrue just to the patient who's able to be treated for that resistant infection. They accrue to all of the other people in the population who don't have to worry about getting that infection because it's effective, that resistant infection, because it's effectively managed, and who can go on to get surgical procedures or other significant medical interventions that otherwise might be too risky for older Americans, for people with higher immune risk, might be too risky if there weren't such good antibiotics with effective stewardship in place at the same time. But again, that's not really captured in the decision in a hospital to use or that value is not reflected in the patient that's being treated in the hospital in a fee-for-service payment environment. So, perhaps not surprisingly, all these factors create a market that does not work well for antibiotic development and is turning out to be unsustainable over the longer term. There has been significant disinvestment by major pharmaceutical developers in antibiotics in favor of other areas where there is a lot of important and potentially valuable innovation happening. Contrast antibiotics with, say, cancer treatments or immune therapy treatments, or even some antiviral treatments, and that's a result of these disincentives or these limited incentives for investment. Today, the bulk of activity taking place is being undertaken by small firms, many of whom are just hanging on to try to get to commercialization, and when they get to commercialization are having some real challenges. In 2019, Achaogen filed for bankruptcy less than a year after approval of their first product, and that product in turn was sold at a quite low sort of fire sale, bankruptcy sale price. And even a relatively successful one of these smaller companies, Melinta, recently filed for bankruptcy as for the only financially viable path to continuing to market their drugs. And as a result, investors are understandably reluctant to fund startup costs, development costs, manufacturing and marketing funding costs, all the costs that are, need to be met to keep a priority antibiotic reliably on the market. So growing attention to these problems, the kinds of responses, as many of you know, can broadly be categorized into steps that help push along the antibiotic development opportunities from a very early stage, and those that can help pull them forward by supporting late-stage development and marketing. There are a number of push incentives that have been identified to support new antibiotic development, and this includes in the U.S. A whole set of coordinated incentives, and we have some people from BARDA here today. They may want to provide some additional comments on this as well, but grants through NIH to fund early stage research, CARB-X funds. Kevin will be able to talk to maybe some of these issues as well through phase 1 development, BARDA supports for clinical trials, also, as I'll talk about more in a minute, some new programs for post-market support, and so significant push incentives here in the U.S. to reduce the cost borne by organizations that are trying to bring new antibiotics forward at the early stages, translating into humans and early stage clinical development, and also some similar significant push incentives that are coordinated internationally with those inside the U.S., significant global incentives. So here today we're focusing more on the pull side of the incentives, because there have been less development, less implementation of significant steps here, and especially in light of those late-stage challenges that companies that have successfully taken a drug through the FDA approval process have run into. There have been a number, this is not for lack of effort or ideas, a number of pull incentives have been proposed to help and to support antimicrobials that are able to reach the market, again, with the goal of trying to better reflect that population health, that public health value of these treatments, or the potential value. One category of approaches are so-called market entry rewards that would provide an additional payment for drugs that reach the market, that meet certain conditions for addressing a priority antimicrobial threat. And that might be tied as well to steps like continued availability and appropriate use. These market entry rewards have the potential to strengthen the market. However, there have been some real challenges in implementation, whether a proposal for direct funding, which might require significant funding by some estimates. I think Kevin's going to give us some updates of what might be involved, $1 billion, $2 billion globally for an antimicrobial, or through alternative approaches like a transferable exclusivity voucher for extended exclusivity that could be traded onto another high-value product. That one's been challenging in an era of high public concerns about prescription drug prices. We had a proposal from Duke in the last couple of years, Priority Antimicrobial Value and Entry Reward, or PAVE, that in the U.S. tries to recognize that some significant payments occur outside of government and could be leveraged to support this effort. So the key idea here was to have a sort of a partial market entry reward that would be tied to manufacturers working with other payers to move to models of payment that are more population-based, that not necessarily would make the payers pay more, but would shift their payments to be more on a subscription or licensing basis to limit the additional funding, new funding needed to support this effort, while still providing predictability and this shift towards a focus on population health. But again, that does require some additional new funding. So those kinds of market entry rewards, while good ideas, I would not say have been widely taken up, and there's been a lot of interest in other pull incentives as well. BARDA's Project BioShield has had within it a procurement mechanism for antibiotics that are used as medical countermeasures. I was in government when that program was first established, and it's made a big difference for, say, countermeasures for threats like smallpox or anthrax and the like, but hasn't, at least until recently, been applied so much in the antimicrobial resistance area. And then there are other proposals that would build on existing payment systems in the United States as well. One important proposal that has a significant amount of bipartisan support is the disarm legislation. It would modify existing Medicare reimbursements to hospitals to give sort of additional add-on payment that reflects the average price of an innovative qualifying antibiotic that's used in the inpatient setting. This is where a lot of the sick patients are who need or would benefit from better treatments for these resistant organisms. In the inpatient setting, Medicare reimburses, as many of you know, under a diagnosis-related group basis, which is a prospective, relatively fixed payment into which payments for specific services and products like an antimicrobial or everything else that happens in a hospitalization, they're all bundled together. So what that means is the whole reason that this payment system was set up was to encourage hospitals to be cost conscious about the services and products that they use during a hospital stay. But the net effect of that is if the hospital decides to use a more higher priced antibiotics, it's going to reduce the net hospital revenues. Congress has recognized that this is a challenge for not just antibiotics, but other new technologies that might add to cost but still be worthwhile. It has established a new technology add-on payment. Historically, that new technology add-on payment reimbursed only 50% of the average additional price, and hospitals have found the reimbursement process itself to be a bit burdensome, especially for treatments that aren't used very often. You know, it's one thing for a new kind of a joint replacement or a new cardiac device that's used in hundreds of patients at a hospital every year. It's another thing for an antibiotic that you may only need to use or should be using only in a few severely ill patients at risk for having resistant infections. So disarm seeks to address this by providing an additional payment equal to the average price of the antibiotic, kind of making it more of a pass-through. So that's kind of the context into which the work that we've been doing over the past year plus has been undertaken. This is through support from the Wellcome Trust, an effort to develop and refine some of the incentive models that could potentially help address these issues with a particular emphasis on the U.S. market, but connected to global incentives underway and global opportunities to collectively improve the return on investment, especially through pull incentives in both the short and longer term. So that's what we're going to talk about today, is building on where we are and where we're headed in terms of pull incentives. And that's why I want to talk about some of the most recent developments in pull incentives in the U.S. as a context for what we'll talk about during much of the rest of the day. BARDA has taken some further steps. Again, those of you hear from BARDA, I hope you'll chime in with clarifications or additions to what I'm presenting. But BARDA has started to provide some funding for clinical stage, late stage products through public-private partnerships, including requests for proposals building off that Project BioShield authority. In this approach, a contract could support milestones like product purchases, phase 4 post-marketing commitments, manufacturing benchmarks as well. So again, something that helps more on the pull side. And the first contract under this approach was awarded to Paratech in December. So that's a potentially important new step to help on the pull incentive side. In this context, and we've had several meetings as part of this effort with CMS leadership as well as other parts of the federal government over the past year and a half, and CMS has taken some important new steps using its existing authorities. In particular, this year in the fiscal year 2020 inpatient prospective payment system, the payment system that governs how those hospital inpatient payments work, CMS has modified its new technology add-on payment overall, increasing that reimbursement percentage from 50 to 65%, but adding on a special increase to 75% for antimicrobials that are designated as qualified infectious disease products. And this is an FDA designation for antimicrobials that really are intended to get at these serious life-threatening disease resistance issues. And it also revised the qualifying criteria so that when these new treatments reach the market, often with non-inferiority claims on the label as opposed to superiority claims, CMS eliminated the requirement that exists in general in NTAP that this new technology, to get the additional payment, has to have demonstrated evidence of substantial clinical improvement or superiority over alternative treatments. CMS also expanded the codes that could qualify a patient with a resistant infection as being in a DRG with complications versus without. That's a significant additional payment in itself compared to not having those designations of complications or comorbidity. And all of these steps together generally are intended to lead to a higher level of reimbursement for patients who are likely to have resistant infections and then are treated with a priority antimicrobial. While a lot of positive comments have been made about these steps and CMS's attention to addressing the problem of antimicrobial resistance, the feedback from the community, including some people in this room, has been also recognizing that while important, these steps do have limitations on their impact. Many hospitals are not participating in the NTAP program, at least as it applies to antimicrobials. Again, these are not used that often, and it is some work for a hospital to apply and participate. And revenue depends on the volume of use still under this model, which, coupled with effective stewardship programs, may not be that large for these new priority antimicrobials. That said, CMS and their involvement with us and many others in these efforts over the past year or two, when these new steps have taken place, have indicated a strong interest in continuing to work on these issues. It's public knowledge that there's an interagency group that's focusing on antimicrobial resistance, in which CMS is actively participating. We're going to talk a little bit more in a few minutes about cross-agency collaborations to try to address the AMR problem. By the way, one of the reasons I'm going into so much detail on these CMS payment issues is that we were going to hear directly from the person at CMS who has been very much involved in these issues, Dr. Anand Shah. Unfortunately for today's event, probably fortunately for the country, he recently was announced as a new deputy commissioner at the FDA, where he will be overseeing a range of innovative reform issues, including, hopefully, AMR. So he is not able to join us this morning. So I'm doing my best job of channeling CMS and our interactions with CMS. But as you all probably saw from first time ever, an administrator has tweeted repeatedly about antimicrobial resistance. CMS has said very clearly that they view this as an important public health problem, one where innovation is challenged by outdated payment frameworks and where further steps are needed to align incentives for developing antibiotics with their public health value. So there are possibilities. These CMS payment rules are annual events. So in 2021 or beyond, further steps could happen there. Would also emphasize, and we'll talk more about this later too, that CMS has some other authorities, some fairly broad authorities to try alternative payment models. that move away from volume-based payment too. And then finally, as I mentioned, CMS has indicated continued interest in collaborations with FDA and other federal agencies to address a lot of medical innovation barriers. There's actually a presidential executive order on this general topic out now, and that includes antimicrobial resistance as well. So some important recent steps just in the last year or so, but I think a general agreement that additional reforms will be needed to better align incentives with the value of priority antibiotics. So I talked about the details of the disarm bill, or some of the key details of the disarm bill a few minutes ago. That is still very much a live consideration right now in Congress, with organizations, including a number represented in this room, Pew and others, providing important leadership in supporting this legislation that would aim to, as I said, pass through the cost of priority antibiotics in the inpatient context. This is something that could be relatively straightforward to implement in existing Medicare payment systems. I would say the CMS administrators expressed some concern about sort of full pass-through of drug costs. That's an approach to payment that in other areas of drug reimbursement, the administration has made some pretty bold proposals to move away from, move more in the direction of outcome impacts and value rather than direct volume. But this is very much a live proposal on the legislative side too. And just want to highlight, as you'll hear more about today, we have just released a subscription approach to payment within Medicare's existing authorities, a proposal for a subscription approach to antimicrobial payment within Medicare's existing authorities, kind of an alternative payment model to build on and add to these traditional fee-for-service payment incentives. And this is an idea that reflects proposals, at least high-level proposals, from people like former Commissioner Scott Gottlieb at FDA to try to move to more of a licensure model or an advanced commitment to purchase a needed volume or an expected volume of a priority antimicrobial for a population. That's the way that Project BioShield has worked, for example. So this would provide both an advanced commitment to a certain volume of sales, potentially making it much easier for hospitals that otherwise would have to go through the NTAP process in order to get access to the antimicrobial. And also we describe how, even though CMS does not have explicit authorities to set a price for a treatment, CMS does have a lot of authority to make alternative payment models linked to outcomes and other indicators of value that go beyond traditional fee-for-service payments. So you can think of this proposal as a combination of a pre-commitment or a licensure model for an antimicrobial plus an additional payment factor that reflects its expected impact, and then hopefully over time, if these models are implemented, measures of the actual impact of the antibiotic on containing the spread of resistant organisms. So these subscription models, just like other value-based payment models in Medicare and in the U.S. private sector, could be linked to other measures of value, stewardship measures, outcome impacts, as I described before. As we'll talk about today, these subscription models are starting to gain traction in a number of other countries as well, and we'll have a chance to discuss where these can work, where they can't, what some of the concerns are about administrative timing to implement, about working out the details, and whether these approaches can provide a timely enough assistance or add-on to helping to improve markets for antimicrobials. But at this point, so I'll talk a lot about those details later, I just want to emphasize again how this shift towards reimbursement based on overall population health value is different than reimbursement based on volume sales, where the focus is on value to the individual using the treatment and the hospital that is treating them. So when a hospital treats a patient with a resistant infection, that, if it's treated effectively, that's clearly valuable for the patient right there. Can also help reduce costs to the hospital in its DRG payment if a patient has a shorter stay and fewer complications as a result. However, there are a lot of components of value at the population level that aren't reflected in that hospital level transaction and care delivery. Some of these are listed on this slide. Downstream costs of complications if a patient subsequently is readmitted or goes on to develop further medical complications because the infection may have been treated well enough to get the patient out of the hospital but wasn't eradicated. And then very importantly, reduction in the spread of resistant infections to others in the population. Medicare's population in particular includes a large number of individuals who are going to be in that program for the rest of their lives, who often have health issues that reduce their ability to fight serious infections and increase their susceptibility to health problems from resistant organisms. On top of that, many Medicare beneficiaries, because of immunologic or other health issues, are higher risk when they undergo surgical procedures or other types of interventions that are very important, potentially very important for improving and extending their lives. But if there is a significant risk of resistant infection, they're no longer good candidates for those procedures. So those are sources of value that do not get captured directly in that individual transaction or that individual use of an antimicrobial in a particular hospital patient. So these kinds of population health values are what many of the subscription or population-based payment approaches are intended to address, and we'll talk more about those today as well. Other reforms are also important to consider in the context of addressing the development of priority antimicrobials. The other steps could increase the value of these antibiotics or reduce the cost of keeping them available and effective over time. And we're going to talk about some of those issues today. Opportunities like improvements in diagnostics to help identify which patients really could benefit and really would be worthwhile to use these antibiotics in. We don't have such rapid, highly reliable diagnostics for many bacterial infections today. Effective stewardship programs, CMS and hospitals and our health systems have taken important steps in recent years to step up stewardship programs. Partly that's because it's a Medicare condition of participation that's been tightened. Partly it's because of increasing technological capabilities, so better IT systems that can help bring the right guidelines to use in particular patients. But those only work well if the guidelines are up to date and the IT systems are also aligned and supported to help treat antimicrobial resistance as effectively as possible. And we'll talk some about how well those programs are going today and opportunities for the future. I would also say that coupled with the efforts around tracking resistance nationally that CDC and others are involved in, these improved data capabilities, these improved electronic data capabilities could also support data evidence generation on help give us a better way to support effective strategies for addressing resistance. So all of that is by way of context to get us to what we're focusing on today, and that includes emerging opportunities to support innovative payments through payment reform, innovative products through payment reforms, public health and health system initiatives. We have a lot of perspectives that you hear from on these issues. It includes identifying feasible steps to improve payment mechanisms, and especially with this emphasis on the pull supports, things that can be done in the late stages of development and to support marketing and sustainable availability of priority antimicrobials, especially approaches that don't require major new kinds of legislation or major new sources of funding. That's why I emphasize in these subscription models like the one that we've recently proposed, that can be done under existing Medicare authorities and a reflection of existing ways that Medicare uses to calculate and implement value-based payments. We'll also explore further opportunities to leverage ongoing health system activities to improve the value and impact of innovative antibiotics. We've got a number of representatives from health systems that are undertaking leading efforts in this regard in terms of stewardship programs, IT approaches, development of new diagnostics and the like, as well as concluding today with a review of, based on what we've heard, what are some of the most promising next steps to advance and improve the ecosystem for priority antimicrobial products. So that's a bit of an overview of the goals for the day. We've got 4 sessions you're going to hear from. So first, we'll be turning right to highlighting some of the U.S. actions on antimicrobial innovation, payment, and stewardship. You've gotten a preview of that from me, doing my best Anand Shah channeling of some of the recent CMS initiatives, and we'll hear some CDC and other and bring in some other perspectives on this in our first session. Then we're going to hear about some innovative approaches both in the U.S. and elsewhere in the world to get to sustainable reimbursement for antibiotics, so some opportunities to talk about that disarm proposal and some of these subscription or licensure or population-based approaches, among others. Then we're going to hear about some of the other actions, like the ones I just alluded to, that could contribute to a healthy antimicrobial ecosystem and potentially stronger incentives for the development and appropriate use of priority antimicrobials. And the final session with people who have some great experience and perspectives to bring to this set of issues on where we go from here. So that is an overview for the day. Just again, we'll be taking a lunch break after that second session, and then a short break between the third and the fourth in the afternoon before we finish up. And so for right now, I'd like to get us going on our first session of the day, which is on highlighting U.S. actions for antimicrobial innovation, payment, and stewardship. Again, I've already talked a lot about some of the recent U.S. actions on payment, or especially the Medicare reforms and some of the BARDA reforms. So I'd like to ask Michael Craig, who's our first speaker, our remaining speaker in this session, to come up. Michael is a senior advisor for antibiotic resistance within the Antibiotic Resistance Coordination and Strategy Unit of the Centers for Disease Control and Prevention. He is going to talk about the activities that CDC is engaged in to combat AMR and improve stewardship of the drugs that we do have and contribute to improved surveillance, infection prevention, tracking, potentially ways of better measuring the outcomes that we want to prevent and the goals that we want to achieve in terms of protecting the health of the population related to AMR. And then we're going to have some time to discuss all of this and hopefully bring in some perspectives from all of you. So Michael, please come on up, and thank you.
And thank you, Mark. Thanks to the Duke Margolis Center. Thanks to Monica and the Wellcome Trust for sponsoring this ongoing work. Really appreciate the opportunity to talk to you about what CDC is doing and talk to you about the greater context for antibiotic resistance, including some of the work that we have accomplished over the past few years. And I was thinking about the title of this talk, and I was trying to not be long-winded, and so I was also in the car with my children, and we were on a long road trip, and they did the proverbial, "Are we there yet?" And I started thinking about that's the very concise way of describing where we are as a country and as a globe related to antibiotic resistance, because it both conveys that we have come a great distance, and it also conveys that we are irritatingly far from Disneyland. Or wherever it is that we're trying to end up. And so wanted to just note that. And I think we also know that always the answer to this question as a parent or someone in the car with a child is no. We're not there yet. And I think the report, the new iteration of the threats report that CDC put out in 2019 that we led underlines this problem. Fundamentally, in one sentence, what we said was that the problem of antibiotic resistance in the United States is worse than we previously estimated. And while the data show that we have made progress on many fronts, we have the burden of resistant infections is affecting more people in the U.S. There are more deaths in the U.S. than we previously understood. There are new threats that we are facing globally. Some of them are threats that we didn't even know about when we put out the last report, like Candida auris. And these are threats that are emerging. As I like to note to people, these are the threats that we know about as of the publication of this report. There are likely threats and new forms of antibiotic resistance somewhere in the globe that we don't know about right now. And they're likely being transmitted and spread through a variety of means, and we have just yet to identify them. So there are plenty of problems that we know about, and there are plenty of other problems that we simply don't know about. And as I noted, it does show that there are more infections and deaths than we previously estimated, but it shows that we have made a great deal of progress. And I think that's an important point that I want to highlight to everyone here for some of the context that we talk about some of these things, because I think the economic incentives conversations that we're having and that Duke Margolis is leading and that folks are having around the world are critically important. I think we would also just want to underline, though, that they are the means to an end. That the end is not to get just to an incentive, because if we just have a robust pipeline, we still have an antibiotic resistance problem. And we can talk about this and describe that in a variety of ways. Do we need new antibiotics? Do we need a robust pipeline? Absolutely. But it's also not the thing that's going to fix all of our problems related to antibiotic resistance. And want to just underline that, because I think it's an important context for us to keep in mind as we do this important work. And this is some of what we showed in the threats report, and this really highlights why we need a comprehensive report, is that we showed that over the last few years, even though the problem is worse than we previously estimated, that we had a lot of success over the past few years, and notably we had the success in areas that the US government invested in. And those areas were specifically seen in hospitals in reducing the burden of resistant infections, improving antibiotic stewardship, improving infection control across the board. And there have been many things. Mark highlighted them. In fact, Mark, in his previous positions, led some of those activities to improve patient safety and healthcare quality. And those are really paying off dividends and showing that what can be accomplished. All that being said, infection control is also not going to solve this problem. We're not going to be able to get there through just improved use of antibiotics or through just improved infection control or just by developing new antibiotics. We have to have a multifaceted approach to do all of those things. Because the report also shows that we have increases in infections caused by a variety of pathogens, and for even the ones that we have seen progress on, we still see that resistance in the United States is increasing for many of those pathogens, even though the number of infections and the deaths from some of those infections may be declining over the past few years. And so especially in community-based settings, and here we define community as outside of hospitals, we see increases in infections and increasing challenging things that we face. So when we think about this from the CDC public health perspective and what we need to do as CDC and protecting human health, we think about it in this context of fighting antibiotic resistance where it happens. And we have to have a multifaceted public health response to be able to address all of these pieces, because antibiotic resistance, as folks I think here appreciate all too well, is not a single disease. We're not talking about fighting HIV. We're talking about fighting a phenomenon that affects a variety of bacteria and fungi, and they are found in different places. These bacteria and fungi are ubiquitous, but they all can be transmitted in different ways. They have different modalities, they have different transmission dynamics, they have different virulence. They all have different dynamics that we have to take into consideration, and there's not really a one-size-fits-all approach to be able to address these things. And we need to identify the reservoirs of where they are and address them and fight them where they are. So from our perspective, CDC really seeks to drive the field forward in the science, and we think of how we can fill the gaps in knowledge that we face through the data that we have, and how we can lend a hand to be able to support things like antibiotic development, but not just antibiotic development, but also diagnostic development, vaccine development, other therapeutics that might reduce transmission. How can we help partner and support this with our science, both intramurally and extramurally? And so, in terms of what I said at the outset, are we there yet? I think it is important for us to note and recognize that the United States right now is doing more to fight this problem than we have ever done before in our history. I believe that firmly. The issue is that it's not enough and that we need to do more. And we are leading the fight and doing more, and we have done more as a country in the last 5 years than we have ever done before. But we still need to do more, and we need to step up and show leadership in a lot of different ways. And these are the 5 areas that we highlight from CDC that make up that comprehensive report of comprehensive way of addressing antibiotic resistance. We have to do all of these things, and all of these things well, to be able to address the problem of antibiotic resistance. And in development of new therapeutics, development of new antibiotics is, of course, a fundamental part of that. But again, we have to make sure that we are making progress on all of these areas, not just in the United States, but really globally, which I think is a context that I think we need to talk more and more about, because we just don't have a good appreciation of what's happening in other countries. And from a CDC perspective, when you don't know something, that's the scarier part. When you don't know what is happening in another country and you don't have data coming in, that is more concerning to us because we have no sense of what the gravity of the problem is or what we need to do to address it. So to highlight some of the things that we have built as a country and some of the things that we are doing on the public health front, just want to highlight that 5 years ago, we did not have an infrastructure, a public health infrastructure in the U.S. to fight antibiotic resistance. With CARB, the first iteration of CARB, and with funding from Congress, we have now a domestic infrastructure in the U.S. that I think is one of the strongest in the world. We have a lab network consisting of support to all 50 states as well as to regional labs that can not only detect emerging resistance quickly, it ties it to a public health response so that public health authorities can go in and make sure that things like Candida auris or an NDM of CRE is responded to, and that the transmission of that is limited and it doesn't spread as it has in the past throughout communities and as spread as widely or as quickly as it does. This has also provided a lot better information about what resistance is happening and what we can do to stop it. This lab network provides not only identification and susceptibility test information, but it also does colonization testing. It provides a service to healthcare facilities so that they can actually determine not only which patients are infected, but which patients are colonized with a resistant pathogen. That's important because CDC puts out guidance to healthcare facilities about what you do with a colonized patient so that you protect that facility and you essentially help isolate that person and make sure that they are not transmitting that to healthcare workers, to the environment, or to other patients in that healthcare facility. This is testing that we are providing free of charge to these healthcare facilities because it is not reimbursed by any insurer or by CMS. And that's important to note because it's one that is protecting the public's health actively, and it is a gap that we have filled and are filling on a daily basis. And you can see there, nearly 13,000 swabs tested to detect resistant germs in healthcare, and those are, specifically colonization. I would also just note that there's a lot we've invested in our state health departments, not just on the laboratory side, but in the response side, so there are boots on the ground to respond to resistant pathogens when they occur. We're also piloting activities globally. It's an area of tremendous need and one that I think we do definitely need to talk more about as a country and how the U.S. government can step up in its leadership globally. And we're trying to do more, of course, on the stewardship side, and I think there is a greater recognition of what needs to be done on stewardship. We have seen tremendous progress on improving hospital stewardship. The core elements that CDC released for hospital antibiotic stewardship, when we first released them and measured hospital uptake of that, it was around 40%. Today, it is over 80%. That being said, antibiotics are not just used in hospitals. They're used in many other settings, and improving antibiotic use across the board in all those different healthcare settings is very hard. changing people's perceptions about when they need an antibiotic and do they demand an antibiotic, and changing doctors' behavior about prescribing antibiotics is very hard. And I think aligning incentives so that everybody understands that antibiotics are not without risk to either the individual patient or to our collective good, and helping people understand to make the right choice for themselves, their family, and for their patients. I touched on the AR Lab Network. This is the state and regional lab network that we're supporting. It is providing faster detection and real-time response in ways that we've never done before. And I think we're just really scratching the tip of the iceberg of what we're capable of finding here and what we're capable of actually doing on the public health side. As I noted, on CDC, we are trying to use our data as helpful and productive in the fight against antibiotic resistance wherever it is. And so to this end, a few years ago, FDA approached us and the challenge that they faced, especially on the diagnostic side, was that a lot of manufacturers were coming to them and testing their new devices against a hodgepodge of pathogens that they personally collected from around the world and submitting the data to FDA and saying, see, this is great and this is effective. And FDA essentially could not do a very good comparison of what is an effective diagnostic and compare apples to apples because everybody was using different data. And to that end, we worked in collaboration with FDA to provide curated panels. So now FDA, when a diagnostic manufacturer comes to them, can specifically say, go test your panels against this, go test your device against these panels in the CDC FDA isolate bank. And make sure that is part of your submission so that we can have a fair comparison to other similar devices and sort of compare like to like. What we have found is that these curated isolates, which we provide free of charge, and we're increasingly providing information like the whole genome sequences of the pathogens as well, had a tremendous utility not just for the diagnostic manufacturers, but for researchers, drug developers, and the demand for this has grown faster than we expected. We don't have, I think, on this the whole slide, but to date, and it's only been open for a few years, we have provided over 100,000 isolates to manufacturers, researchers, diagnostic companies worldwide. And we are increasingly add panels to that. When Seoris was identified globally, it was very hard for companies to obtain it because it was quite rare. CDC obtained it and put it in the isolate bank within 2 weeks of receiving it at the agency. The other thing would highlight here, and this has been a big discussion with some of the legislation and regulatory issues in CMS, as well as some of the legislation that's being discussed, like disarm, of how are we tracking resistance and how can we better track resistance and utility of antibiotic use, especially in hospitals. So the National Healthcare Safety Network, if folks don't know, is the nation's largest healthcare associated infection patient safety tracking system. Currently, over 22,000 healthcare facilities report data related to infections or patient safety to CDC regularly. And it is the system that CMS uses for a lot of their quality reporting for healthcare-associated infections. So when you go to the CMS Hospital Compare website and you look up your local hospital and you see data related to their HAIs for MRSA or C. diff or something, that data is actually from CDC's National Healthcare Safety Network. We have 2 new measures that are voluntary that track both antibiotic use and antibiotic resistance. They are very important modules. Again, this is provided free of service to hospitals and to other healthcare facilities. And when I say it's free of service, it actually does give them analytics and data to compare their performance with other facilities. So it is something that they get an added value of it, and it's not just a requirement that they have to set up. And to that end, I will just note that there is tremendous utility that hospitals have seen in using NHSN, especially for tracking their antibiotic use, because over 1,500 hospitals have now voluntarily enrolled and are reporting that data to CDC and are using that data to compare and benchmark their performance against like hospitals. And we see that there's a great opportunity here for using this data, especially as we expand reporting and as more facilities report their data, to actually benchmark for different types of use and to actually make improvements and make some comparisons. So, for example, the utility that we've seen with this is that certain health systems will say, our antibiotic use is great. They started to report their data to NHSN to sort of validate their notions of it, and they found that their antibiotic use was largely great, except NHSN will break out their data by unit of hospitals and make comparisons and benchmarks by not just a hospital type, but by ICU type and size. And what they found is that for 90% of their units, they were doing great, but they found for some of their surgical units in particular, they were 5 times the national average. And they saw an area of quality improvement and need, and then have really sought to improve that, and then they have made gains and tracked that progress in NHSN. So it gives great opportunity for doing even more than we've done to date. And this just shows sort of the uptake after enrollment and the tremendous growth. And this, again, is all voluntary. Usually we see growth like this after CMS requires or signals that they're going to require uptake of something and put it in a quality measure. This is actually purely based upon voluntary uptake, which for us at CDC, who's developed these tools, feels good because we're actually providing something of great utility in and of itself, and that has a lot of application for CMS and others to maybe expand its uptake further. Would also just highlight some of the work that we just completed on the AMR Challenge. I think a lot of you have heard of this and have made commitments through the AMR Challenge. This concluded this past year at UNGA, but it was our intention from CDC to bring greater global awareness of the problem of antibiotic resistance and to get organizations from around the world to make commitments of what they could do to stop it. The 5 areas that we highlighted before that we need to address are the same 5 areas we wanted folks to make commitments on. And we had great success in bringing in those commitments. And by all means, the year-long effort that we led at CDC to bring in those commitments and to challenge organizations from around the world, including countries, to do more, we felt was quite significant and we felt really good about. And I think it really showed that there is tremendous interest on this. I will just note that this is something that we need to continue to do. We need to continue to not see this just as a solution that is brought to you by governments or a solution forced to you by legislatures. It is one where we actively need to engage constituencies, be they companies, be they private foundations, be they researchers, and challenge them about what is the commitment they can make. And this is true for the individual as well. What are we going to do? How can we change our societal behavior? How can we get to a tipping point on understanding the use of antibiotics and resistance so that we can really do all the things that we need to do? This is the last slide I have, and I just would note that when we think of all the things that need to be done, we sort of break them into these categories. This is a shorthand version of a longer table that's in the threats report that we released in November. And these are the things that we see. And I think domestically would note that we have made a lot of progress. The innovation side and the global side are the things in greatest need. We do see on the global front that we really don't have an idea of the problem of resistance. In the US, we have a threats report that CDC just released. In Europe, we have a good understanding of the burden of resistance. Outside of those 2 places, we do not know what we don't know. And that's a scary thought. And I would also just note that the more we know globally of what is developing in terms of resistance or what are the market need for some of those markets, that will help us on the incentive side, and I think it will help us on the development side, because I don't think companies appreciate what is the global problem. They might appreciate what the European market is, they might appreciate what the US market is, but if we don't have a defined global market or global need for some of these things because we don't have data, how are we able to invest? How are we able to align incentives appropriately so that companies can see that there is incentive for them to develop a new antibiotic? And how can we even know what is the new antibiotic we need to develop? And so that's a key thing that we'll just note. The other thing I think it's also important is that it is not just about antibiotics. For some things, we have a lot of antibiotics to treat patients. We need to figure out what else to do. I think in the United States, MRSA is a great example of this. There are a lot of antibiotic agents that can treat MRSA. Why is MRSA still one of the leading causes of resistant deaths in the United States? Because the issues are different. Because we need other things. We need other modalities like vaccines. We need other things like better diagnostics. We need to figure out how we can reduce the transmission of these, not just in healthcare settings, but in the communities. How can we come up with a therapeutic that is not addressing the treatment, but is knocking down the colonization and reducing the transmission of this wherever it's happening? We need to come up with some of those things for pathogens as well if we're ever able to get out of this problem. And with that, I think I'll close.
Thank you. Great comments, Michael, and I hope that you and the kids did make it to Disney World eventually. But I want to pick up on some of the comments that you had. Again, we're going to open this up to questions and comments from all of you in just a minute. Am I pressing the wrong button?
I think it's the mouth.
How's that? All right. So everybody missed my Disneyland joke. Wanted to leave this slide up on the road ahead and maybe press you on a couple of issues. You started out by saying, by highlighting that better antimicrobials are a means to an end. But then you took the useful step of I think talking about what the end is and how we're measuring that. And in particular, I want to focus on your antimicrobial use and resistance tracking, which, as you know, has gotten much better. You talked about the increased hospital reporting in that area, even without any mandatory quality reporting steps from CMS, although there have been some condition of participation changes that I think probably help there. So just to keep with my channeling CMS focus, what I would have asked you, Anand, is what's the next area for CMS-CDC partnership, or where do you see as the biggest opportunities around that goal? So better data on antimicrobial use and resistance seems like it could be a basis for improving stewardship, for improving infection prevention, and also potentially for improving incentives for using the right antibiotics too. What's coming next in this area? What do you think is possible to build on this recent progress?
So great question, and I think the thing I would just note at the outset is that I think one would just highlight that the collaboration between CDC and CMS is robust. It's one of the unsung success stories, I think, in this space over the past few years, that the collaboration between the agency has been really hand in glove, and it's been really great to see how two different agencies with different public health missions are really working collaboratively with their different authorities and their different expertise to solve some of these issues. And I think that's positioned us so that we can do a lot more. And you're right, there have been a lot of conditions of participation changes over the past few years to better get facilities engaged on these issues and to be able to do more. I think, from the CDC perspective, I think we're wanting to see some of those voluntary uptake of things become maybe more mandatory uptake of things. And we see in some states that some states have not waited on CMS, and in fact, they're requiring it at the state level for all of their hospitals to report some of that data. I think the other area that I think is underappreciated is the interpretive guidance when CMS puts out a rule, and trying to understand what do you do practically at the facility level, and what are you making sure surveyors are looking for, and what is the accountability that's being shown for what they're doing on the infection control side, what they're doing on the antibiotic use side. And I think there's a lot of opportunity there as well. What I would, as the data showed from the report, is that we've made tremendous success in hospitals. Outside of hospitals, we are not seeing the same level of success for these problems, either in improving use or addressing resistance. And I also just don't want to say, just because we've seen success in hospitals doesn't mean that we're always going to see success. We have to be vigilant on that. But outside of hospitals, in nursing homes, in skilled nursing facilities, in the new ventilated skilled nursing facilities, and all these different types of settings that we have with our unique system of healthcare in the U.S., we have to figure out how we can have good use of antibiotics and appropriate infection control.
And it does seem like with these data and this tracking, you've got a basis for moving to really focusing on that end goal of appropriate use, preventing infections, and using new antimicrobials effectively. We're going to hear from some hospitals and some integrated system perspectives a little bit later in the afternoon today, so we get their take on what they think of maybe more mandatory steps, or at least more payment reforms, other steps in the same direction to create this broader alignment around overall goals. But it does seem like the U.S. is changing in that regard, although further steps needed. You talked about global coordination. Can you say a little bit more about what you see as the best opportunities for extending this same kind of systematic, goal-oriented approach, evidence-based, measurement-based approach outside the U.S.?
Yeah. So on the global context, as I noted, I think that's the biggest challenge that we face collectively. And as I noted, we just don't know what we don't know. And I think it's one where the U.S. government is leading in so many regards, as my slides noted, and I think we have developed new things like CARB-X. We have developed new things like our AR lab network, which I think are showing what is possible and what needs to be done. And I think there has been sort of a collective recognition of the need for some of the things that the U.S. government has created over the past few years. All that being said is that it's also showing us how inadequate where we are is right now. We need to do a lot more on a lot of different fronts. And I think a few years ago, we thought that if we developed something like CARB-X, it would do a tremendous amount of effort, and it has, but we're also in a place where companies are going out of business. So clearly it's necessary, but it's not sufficient to fix the problems that we have, and we need additional reforms. And I think the U.S. government needs to better articulate its leadership on the global front to not only improve things on the incentive side, but really improve and showcase what it has done in improving infection control, in improving antibiotic use, and really get engagement with other countries, get better engagement with WHO to take better action. And at the end of the day, I also think that this is a problem that we are not going to see success in until there is greater collective investment, which I know is a hard thing right now and it's always a challenge. But when you think of something like HIV and the global problem that we had with that, we did not really start to turn the tide until we had something like PEPFAR. And we had U.S. leadership and investment to do something like that. And we need to recognize that this is a problem that's not going away, and we can either pay now or we can pay later. But we are going to pay as a country.
Yeah. I would like to open this up to comments or questions from those of you here. So again, just so everybody who's participating in the webcast can hear you as well, please head to the microphones and let us know who you are when you ask your question. And we'll help you out with that too.
Hi, Jumana Musmar with the PACCAR. Michael, you showed the slide that had the trajectory of participation in the network. What happened in 2016 where all of a sudden you see an exponential increase?
So I think there are a couple things. One, there was some engagement with CMS where I think they had noted in some rules, and they had sort of hinted at that this was something that was sort of newly available, and it could be something that they are considering. So they sometimes preview coming attractions that they could be contemplating mandating in future years. And I think it was one that we did a greater collective effort at CDC to get the word out and to showcase what is possible. And we had some great success stories from early adopters of hospitals who really became apologists for sharing that this was something that was free and it had great utility for them as a health system or as a healthcare facility in understanding what they were dealing with and how they could benchmark their progress.
We're going to have a little more hospital perspectives on this and health system perspectives this afternoon too, so more to come.
Just as a follow-up, do you foresee that these numbers may actually increase a little bit more considering the recent conditions of participation being passed?
Yeah, we have seen them continually grow up, and as you can see, the slope of the lines, especially on the antibiotic use option, we have been incredibly impressed that it's been about 100 facilities we've been adding per month over some of these periods of time, which is on a voluntary basis a lot. It's great. It's also a lot of work to make sure everybody is getting their reporting in appropriately.
Okay, thank you.
So, just if I could build on this question too. So, a growing number of hospitals and health systems in the U.S. are not only continuing to pay attention to the Medicare condition of participations for their hospital payments or otherwise, but are moving into alternative payment models where they're being paid more on a population basis overall, something more like per member per month in a Medicare Advantage plan or ACOs or the like. And those organizations also are trying to invest more in steps to improve population health outcomes. You see this as being a potential basis for interaction with those.
I think it definitely is a basis for interaction, and I think it's also a basis for studying with some of this data whether those new models are better than some of the old models, whether we actually see improved antibiotic use with the way they've organized themselves and done some of these things. And I think it's something that we need to look at again and assess with a consistent data stream to be able to understand what's working and what's not.
Great. Kevin.
So we'll talk about a lot of long-term solutions today, but one short-term solution might be Medicare, payment reform, getting antibiotics outside of the DRG, either through
disarm
or through the IPPS rule in this April, the proposed form. I was wondering what CDC thought in terms of are there ways to do that so that we can be confident that stewardship would be maintained after antibiotics came out of the DRG? Have you thought about that? Is there suggestions that you have?
There's a lot of things that we've talked about internally and with some other organizations. A couple things we just note to you. Some of the things that we're thinking about is whether NHSN, especially our antibiotic use option, can track the uptake of that, especially if we have new drugs come to market and they're incentivized, if we can have maybe a requirement by CMS that they have to use this so that we actually understand how they're being used and there's transparency of the data of their utility and the application of their use. I think the other thing that we're contemplating is that there's a lot of conversations going on about how do we make sure that appropriate guidelines are making sure that new drugs coming to market are being taken up appropriately and quickly when they come to market. And is there something that we
that depends on timeliness of guidelines too, right?
It depends on timeliness of guidelines. It is a challenging process, and it's one that we have talked to IDSA about, and I think we have a shared partnership and commitment with IDSA that we want to work with them on. Are there ways that we can do this? And working together to improve and shorten that time frame? Can we give better guidance to clinicians about these new drugs, what they are, and what is their utility? I think we can do a lot of that, and I think we can get guidelines out faster, and I think there's a lot of potential for that. I think there is still going to be a challenge, as you noted in one of your slides, that there's still not necessarily going to be all the data that we want to have for those new drugs. So some of the time we might just be saying, we think it could be used for this, or it might have applications for this, but there's no clinical trial or there's no other study to actually show that. And it might be a couple years with that being on the market before we get to that level of information to where we can update a guideline and they can affirmatively say, even though this is a new drug, it is vastly superior to everything else and you should be using it first.
This does seem like a good data infrastructure for helping to update the guidelines and confirm that the benefits are there or not. We're running tight on time, but I see potentially 3 good questions, so we go through these quickly, try to get them in.
Okay, well, I don't know how good they'll be, but Neil Clancy, University of Pittsburgh, I'm an infectious disease physician. So, why don't we restrict who can prescribe antibiotics? Why shouldn't we have some sort of certification or basic qualification level to be able to write a script? Is that something that's feasible and workable? I would never give a cancer chemotherapy drug.
So that's a further step.
It's a further step, and I think it's one that we might defer to IDSA on some aspects of that. But I think the challenge that we face with antibiotics that's been highlighted is we both have these public utility challenges where there is a collective need for them, but we also have the need and the recognition that they're life-saving treatments. And that if we go into a situation where we're restricting their use in some way, I think there is concern from CDC and others that we are going to then get in a place where people who desperately need them, people who are septic, aren't going to be able to get them in a timely way, and they will ultimately die. We do have some challenges with identifying sepsis and making sure that that treatment happens rapidly and is recognized and they get what they need. And so it's one where, stewardship is hard and changing behavior is hard. And I think we're open to try and figure out how we can balance that dynamic of access with need.
We're going to come back to this topic during the day, so please hold that or feel free to follow up on that question in the later panels. Yeah.
Thanks, Mark. Monique Mansour, the Miter Corporation. Mark, you've got the long view in Project BioShield from its crafting to its current implementation. Its intent to be a market maker. So the pros and cons of sort of understanding that this is both a public health and a national security or health security threat, global security threat. Can you speak to that and what role Project BioShield, does it have the authorities to be, at least in part, the market maker here?
Well, yeah, I touched on that, and I know there are a couple of people from BARDA here. If they feel like they'd like to comment on this now or think about it, maybe comment on this a little bit later in the day when we get to next steps and things like that, I'd welcome that input. But technically, as long as it is a national security threat, that does fit within the BARDA authority, and BARDA has proven it's got some good capacities for not only supporting push incentives we talked about earlier, but especially with these kind of milestone-based payments. Those have unquestionably worked in getting us better prepared with national countermeasures and the like. So it would be a step onward, and I think that's worth continuing to discuss as we go forward today. Yeah. And by the way, I'm the moderator. I'm not supposed to be getting the question. So it's okay.
Well, I suppose this would be for both of you. So thank you both for really informative presentations this morning. So I noticed that in your slide where you were covering where we've seen some decreases in antimicrobial resistance, we were stable when it came to drug-resistant tuberculosis. And I think, that's largely due to the fact that globally we have a challenge with access and affordability of drugs for drug-resistant tuberculosis. So I was wondering what sort of approaches you thought might be most helpful in addressing that access and affordability issue that we're seeing as sort of the main cause there.
Yeah, I think, and for TB, we put on that slide, I think we have TB and CRE both as stable, and we consider that a success because there have been a lot of public health interventions, and I think there's been a lot of perception for some of those things that we're just going to see increases. And you're right, we've seen global challenges ongoing, and the number one infectious disease killer globally is tuberculosis. And we can't forget that. And I think there is a tremendous challenge that we face with access and utility of antibiotics. And it's not just for TB, although TB is a great point. I mean, there are some significant challenges in the supply of getting penicillin where it is needed for the treatment of infections globally. And if penicillin is not available, then what happens in countries is they take a new drug that is way more potent and one that we would want to preserve and one that in the US our doctors would never think of using for certain things, and they blast that infection with that and again start the process of cultivating more resistance because of it. And so I think that's a greater recognition, and I think somebody once said, and I think it's a very good point that we underestimate, is that antibiotics can cover a multitude of sins. And that practically means is that antibiotics are often used in situations to cover up the fact that we have poor infection control, that we don't have a public health infrastructure, that we don't have a lot of other things in place. We don't have clean water. So give somebody an antibiotic and have them swallow it with unclean water. And that's what we have used antibiotics for in a variety of ways. And I think we just need to have a greater recognition that when we have a new antibiotic, we need to be paying attention to its utility not only in our country but around the world, because that resistance is ultimately going to be global if it develops somewhere and gets disseminated. And then what can we do to improve access to all of these antibiotics, whether they're new or whether they're old? Because it might be very much that we want to actually improve the access to not only the novel antibiotic that we develop, but to penicillin. And how can we do that in a way that is equitable and ensures improvements in stewardship as well?
Great. Michael, thanks very much for an excellent discussion. We really appreciate your being here. Thank you.
Thank you.
And we're going to go straight into our next session. So if I could ask our panelists to come up and if we get their name tags up so they know where to come up to. This session is on developing a path to improved and sustainable reimbursement for antibiotics. And I think it's a great follow-on to that last question and much of the discussion that we had in the first session around the context and the changing ecosystem in which these antimicrobials are being developed. So if I could ask, now that you know where to sit, if you're on this panel, come on up, and we're going to continue with the discussion of incentives and payment reforms, including additional payments, reward mechanisms, more fundamental payment reforms. For this discussion, we're very pleased to be joined by Michael Cheng, principal at Adjuvant Capital, one of the few people in the industry who's not in San Francisco right now. Thank you. I'm really glad that you could make it. Nick Crabb, program director for scientific affairs at the National Institute for Health and Clinical Excellence. Suzanne Edwards, an economist at the UN Global AMR R&D Hub, and Monica Schneider from right here at the Duke Margolis Center for Health Policy. They're each going to start out with some opening comments before we move on to discussion of these issues around improved and sustainable reimbursement for antibiotics. I'm going to start with Michael, as we really would like to get this investor perspective on how the antibiotic market looks now, given the trends that you're seeing, including some of the ones we discussed so far this morning. Where's the promise? Where's the opportunity, and where's the worry?
Yeah, absolutely. Thanks, Mark. So I am.
Okay.
Is this on?
Yeah.
Yes.
Okay, good.
So as Mark mentioned, most of the industry is currently out in San Francisco for a major healthcare conference. I was lucky enough to get out of that.
And we were lucky enough to get you here. Not easy.
So wonderful to see all of you. Just a little bit of quick background. Adjuvant Capital is a little bit atypical for your venture capital firm, especially operating in life sciences. We were started back in 2013 by the Bill and Melinda Gates Foundation and JP Morgan to test out a venture capital model to fund global health technologies. So we're now on our second fund. Our bread and butter tends to be mid and late stage development of drugs, vaccines, and diagnostics for high burden and neglected diseases, as well as maternal and child health. So up until our fund, that sort of VC taking an equity position and board seats in a company within global health development had never been tried out. Given that we're now on our second fund, we've had some level of success in both, bringing products to market, but also realizing a, rate of return for our investors. So antibiotics are something that we did not focus on in our first fund. We were doing mostly vaccine development and MNCH work. That said, with this second fund, we've opened up the mandate a little bit to start to try to address this problem. So I think that just in the first few minutes, what I'd like to comment on is, first of all, just like what we're seeing in the landscape as investors. And then I can comment a little bit on the investor's perspective, how we look at these investments and why antibiotics have been so tough, not just for us, but for the broader investor community. And then just a few comments on some of the push and pull mechanisms that, we've used in the past, but also that we've seen. So real quickly on the landscape, as Mark mentioned in his opening comments, we have seen sort of an acceleration in bankruptcies and companies having to either sell at fire sale valuations or just going away entirely. This has been highlighted by two this year, as that's in smaller companies as well as larger big pharma pulling out of the space, right, shutting down their programs or divesting their programs. This has really created, I think, two big problems. For one, and it's one that's often actually not talked about much, is we're seeing the talent pool of people that really know how to discover and develop antibiotics is starting to shrink. Which is not just a problem today, is that there's fewer teams out there that we can go talk to and look for good investments, good solutions, but also in the future, obviously, as the talent pool continues to shrink because of the lack of funding, this could create a real bottleneck in the industry. And as far as the investor perspective goes, we talked a little bit about ROI earlier, right? The big problem here is that as everyone knows, it's very expensive to develop a new drug or vaccine, no matter what kind of drug or vaccine that is. And if you don't have visibility on revenues, for one, and two, an exit, in other words, how are we going to sell our stake in this company? It's very hard for VCs to get involved. And I think one of the sort of tangential problems with big pharma pulling out of the space is that there's now kind of a dearth of acquirers in the space. So not only do you have the problems posed by volume-based reimbursement as far as lack of revenues for these companies, but in the event that you do have a company that's able to stay afloat, there's a real lack of big acquirers that would come along and buy the company. And as an investor, that's something that always goes into our calculus. You know, our funds have 10-year lives, right? We have 5 years to put the money to work and 5 years to realize a return on those investments. And if you don't see a robust acquirer landscape in a space, it makes it very, very difficult. So, you know, as what we have here is really, it's like a perfect storm of lack of visibility, right? And so we meet with a lot of antibiotic companies because, you know, we're one of the few investors in the space that will take a hard look at them. And, you know, what we've seen is that the lack of revenues, the lack of visibility on revenues due to the reimbursement model, the lack of the exit landscape, coupled with, you know, technical challenges and the technical risk, you simply can't balance the risk reward. And, you know, as such, you've seen most VCs won't even take meetings with some of these small companies these days. Lastly, what I'll say as far as the solutions, we have bumped into, you know, CarbX, the Repair Fund, you know, GuardP, so on and so forth. A lot of these push mechanisms are really catalyzing R&D in the space, and we're seeing some good science out there. But what we really see is that some pull mechanisms are really needed here. That's really just to decouple revenues from volumes, whether that's in the form of a market entry or a subscription model, as we'll talk about later. Market entry we see, you know, somewhat similar to the PRV mechanism that was used for neglected diseases. That's, you know, a good way to get people to come into the space. As far as creating sustainability, you know, I think that, you know, the subscription model, as far as if you want to create sustainable companies, is probably going to be more attractive from an investor's perspective. And something I'm happy to comment on more is we've used the PRV mechanism for neglected diseases twice in our first fund, once to a success and once to a, you know, a lesson learned, I would say. So we have seen success for some of these pull mechanisms, and excited to talk a little bit more about, you know, how we can kind of further that for the ABX space.
Great, and I look forward to coming back to all of that. Right now, I'd like to add that context to some of the other perspectives we have on the panel, starting with Suzanne. You've been focusing on this problem from a more international perspective, and I know the Global AMR Hub has some new activities underway intended at least to provide more visibility, if not yet a full solution to some of the issues that Michael was describing. Can you talk a little bit about what you're seeing and thinking about?
Yeah, Thanks, Mark. So yeah, I'm from the Global AMR R&D Hub. We were formed actually by the G20. Last year was our first full year of operations, so we're finding our feet at the moment. Our board is currently comprised of 17 countries, many of whom are G20 countries, which is great. We also have 3 donors, so Bill and Melinda Gates Foundation, Wellcome Trust and European Commission, and 4 observers on our board, so that's a nod to the UN. So we have the World Health Organization, the World Organization for Animal Health, the Food and Agricultural Organization, and the OECD. So our mandate is global, and it is to inform and to improve the high-level coordination of activities and investments in this area. So I represent the rather small secretariat in Berlin, Germany. And I'm working at the hub to sort of shape our approach moving forward to the incentive piece of this. The primary tool that the hub envisages at the moment in terms of this high-level coordination is gathering together a database of R&D activities and investments that are going into the space, and that will be also across One Health sectors. That will be fully public this year, and you'll be able to interact with that through a public dynamic dashboard, so different users can use that to extract the information that's most relevant for them. And the data will expand incrementally as we're able to get our hands on it. So in specifically with respect to incentives, the first half of this year, we will be focusing on actually trying to collate all the activities in this area to pull them together into one place and give that visibility across the whole value chain. So whether they're regulatory, legislative, new financing instruments, that's the main task that we're working on for this year. We've heard this issue of visibility and how to improve working across different countries. The session this morning was super helpful from that perspective to really see the concrete steps that the US is taking, which is absolutely great. So the meeting's very timely from our perspective, so thank you very much for that invitation. And just a note on that this morning, that to see so much stuff happening in the US is really great. I mean, from a value perspective in these global markets, you really do hold the single biggest piece of that pie. But at the same time, US action alone is going to be insufficient to fix this problem. So our hope is that we can, through visibility, through being a global platform, that we can contribute to fostering that sharing, taking forward some of the learnings from some of the pilots and some of the other activities, basically with the intent to expedite implementation further around the world. So, in addition to capturing the world of incentives, we are currently commissioning a couple of studies in this post-market space. Unfortunately, I don't have results to share with you today, but Duke have very kindly let me make a shameless plug that links to these calls are on our website for anybody listening who may be interested in replying to them. I will mention the first one, the perhaps least relevant, not to this topic, but at least to this session about reimbursement first. And it actually pulls on a point that Michael made earlier. We hope that this will be imminently live, if not this week, then perhaps next week. And it supports the work of our expert advisory group, so 17 transdisciplinary experts from around the world who have been tasked by our board to try to understand market potentials in this space. So by market potential, we're talking about not only patient numbers, but also revenues. The group has identified 4 products to meet some priority needs, so 2 diagnostics and 2 therapeutics. And they're going to try and quantify that both in the moment and then projections 5 and 10 years into the future. So when thinking about this post-market space, particularly from a global perspective, transnational studies, obviously you see great heterogeneity across health systems. But despite that, there are process commonalities from the point that a product is approved right until it's taken up by the patients. So there are some commonalities, and we've chosen 2 points along this for our second study, sorry, that I will mention, was live last week. Now, I will also hold my hand up and say that both these studies sort of don't directly address the key issue of value, so I will leave that to Nick, who's going to talk about that in a minute, is really much more the expert than I am. But surely this question of defining value and how to incorporate that is a key one. I was also quite happy for this study I'm about to talk about, that it aligns actually very well with the actions that were displayed this morning from the US. So the general hypothesis behind it is that actually health systems may well have the tools. The tools may well exist to ensure that these products are valued appropriately. And actually by looking out of this little AMR silo, maybe we can realize, illuminate some paths forward. Some of these challenges are not unique to AMR, although obviously the totality of the challenges are very unique to antibiotics at least. So the idea is whether we can, by looking to other areas within health systems specifically, whether we can highlight some concrete paths forward. So the studies will cover 8 to 10 G20 countries, will cover both novel antibiotics and rapid diagnostics. The first part of the study is to look at this issue of a cost containment exception, what tools countries already have within their health systems to either carve out or top up the valuation of these products. And the second part, which I think the discussions are perhaps a little bit less advanced, are on atypical contracting modalities that could be used that would address some of the challenges that we have with low volumes and other things. So maybe I leave it there. I'm happy to talk further about the studies, of course, a little bit later. Now, we're not quite sure what's going to come out of these studies, if we are going to be able to illuminate concrete paths for action for other countries, for the US as well, but at least it will give us something to really start concretely progressing that conversation.
Yeah, thank you, Suzanne, and we've been pleased to be part of this effort to develop these models, as you say, both for topping off payments in fee-for-service or otherwise systems that otherwise haven't done a great job of recognizing the value of antimicrobials or diagnostics, for that matter, as well as showing how that might be a connection path forward into these more directly value-focused models. So looking forward to more work on that. And Nick, you're in the midst of this kind of transition in thinking and payment, or at least some initial steps in this direction in the UK. So I was wondering, I know you've been very much involved in pilot work there on moving to something more like a subscription or population-based model on top of the existing payments, or replacing the existing payments for antimicrobials. So looking forward to an update on how that's going.
Great, thank you very much, Mark. So in the UK, we have a very sort of comprehensive national action plan on antimicrobial resistance, and the plan overall is very broad and covers many of the areas that Michael talked about in the earlier session today. So I'm going to just concentrate on the specific projects on the development of new models for the evaluation and purchase of antimicrobials. Now, this is a commitment in the 5-year National Action Plan for AMR that was published in January last year. And it commits us to testing solutions that will address the sort of the global failure to incentivize the development of new antimicrobials. I think people in this room have a really good understanding of the sort of market failure, but one sort of illustration that we found very helpful, and we find it very helpful when sort of stressing the urgency of this work, is just a quick look at the pipeline. So when we last checked, there was sort of 42 new antimicrobials in phase 1 to 3 clinical trials. And if you just compare that to just one area of oncology, so the immuno-oncology agents, there's around 3,400 products in clinical trials. So that to me is quite a nice sort of illustration of why work in this area is so urgently needed. Now, the current project that I'm involved in is co-led by NICE and NHS England, the payer in England. And the aim is to demonstrate the feasibility of innovative models that pay companies for antimicrobials based on a NICE-led health technology assessment of their value to the NHS, rather than paying on the basis of the volumes used. And the idea is that the NICE assessment will inform commercial negotiations leading to payments to companies in installments over a multi-year period. Now, recognizing that capturing the value of antimicrobials is really quite difficult. Before this sort of current pilot project, we sort of, with the Department of Health and Social Care, we commissioned some sort of research on the evaluation methods. And this work was undertaken by the Department of Health and Social Care's Economic Evaluation Policy Research Unit. And their report was published in October 2018. I thought it was a really important piece of work, and the report concluded that in principle, capturing the full value of antimicrobials using an HTA sort of framework was possible, but that it was also very complex. But there was scope for a pragmatic HTA framework that made good use of economic modelling where possible, but also expert opinion. Now, of course, as other speakers have already said this morning, the assessment of value needs to capture the value not just from the direct health gains to patients treated, but also additional elements of value. For example, the insurance value, diversity value, transmission value, and enablement values. Now, the plan is that the model will be developed and tested through application to 2 products. And future policy for the evaluation and purchasing of antimicrobials will be informed by the outcomes from this project. So just a little bit on where we're up to. We launched the project in July last year. We put draft versions of key documents, things like the topic selection criteria, the evaluation framework, and also an outline commercial model. And these were developed and then shared with stakeholders through a targeted engagement exercise. We were really delighted with the level of interest and the level of international interest, and we got some really insightful responses from many organisations. So we're very grateful for that. One of the things we're sort of working on in a great deal of detail at the moment is the sort of detailed process and timelines. In particular, because we're sort of because we're actually piloting the whole process, so the contracting process as well as the evaluation process, it does mean that that in selecting the products for this exercise, we are going to have to make sure that everything's compliant with sort of purchasing regulations in Europe, and that's one of the areas that we're putting a lot of focus on at the moment. So just thinking about what success would look like. If we get to the point where we have successful value assessments, we have actually been able to capture the value for the 2 products. If that evaluation then leads to successful commercial negotiations with the actual subscription style payments in place for those 2 products, we would consider that to be sort of, I guess, the sort of first level of success. But understanding that models like this in England alone will not go very far in solving a global problem. Real success is sort of working with others, including the people here today, so that between us all we can sort of achieve models that work in our own sort of jurisdictions, and that together we'll achieve effective pull incentives for the development of antimicrobials that really will stimulate companies to increase investment. Just one other thing. Obviously, again, it's been mentioned earlier. Whatever happens commercially here, it's so important that the models do also result in robust stewardship of the products. Clearly, if we introduce incentives, but then the products come to the market and they're not used against strong stewardship regimes, that wouldn't be something that any of us would be able to support. So clearly for this project we need to get the antimicrobial stewardship right, and a lot of the work that NICE is already doing in the sort of antimicrobial resistance area is supporting stewardship through a range of syndrome specific sort of guidelines. I think will that be enough for now?
Great. That's a great start. So as I think the other speakers have said, we're it's Michael's term. We're not there yet, so I'm going to come back to next steps on this. But that's a great overview of where the UK is and where it's headed, both in terms of the increasing emphasis on stewardship, which is something we heard about in the US as well, and maybe other countries, and in terms of trying to recognize more of the whole value of these priority antimicrobials that are needed. So Monica, maybe you can provide some updates or additional perspectives on how things are going in the US in this regard.
Sure. And as Mark, you gave a nice overview earlier in the day, a lot of the work that we've been undertaking at Duke Margolis has been looking at these different incentives and payment reform structures that could be implemented in the US that might bring more sustainability to the market, more predictability, and overall provide better support to the ecosystem. And through a lot of the discussions that we've had, we found that there's a real spectrum of different potential incentives and payment mechanisms that could be put in place. And while there's some big picture goals, like maybe something like a market entry reward, that's a big thing that would be a lot harder to get to. And so in many cases, we're going to need to take incremental steps in order to move away from this system where we're paying for use of antibiotic to really a truly delinked reimbursement mechanism. So I think that it's helpful to consider how these incentives could be implemented, and there's clearly some that are geared towards more of a short-term, immediate implementation to those that would be a further off goal, but something that's worth working towards with these different mechanisms. So the changes that CMS made recently within the previous IPPS rules are a good example of something that is an immediate action that, while it does have its limitations, does have potential to send a strong signal to the market. So there's potential there to also build upon what they have put into place. And where the limitations are, well, maybe this is within uptake in the hospital, ability to implement and awareness and raising that awareness. So the next step along this path might be the disarm legislation that's in place, where it takes some of the burden off of the hospital in order to receive that reimbursement. And just to give a quick overview again, the disarm would provide an add-on payment that would be equivalent to about the average sales price of the antibiotic plus 2%, which would essentially make an innovative antibiotic, an innovative new antibiotic, financially equivalent to using a generic antibiotic in the hospital. So this has a potential to give a big boost to antibiotic manufacturers and the products that are on the market now or whenever it would be implemented, whether this be through a legislative process or if this is something that CMS could potentially do under the current authorities. And this would potentially stabilize the market, but still isn't quite getting to that move away from volume dependence for sales. So both the changes in NTAP and disarm are reliant on these volume-based sales and in order to improve revenue for antibiotics. And neither necessarily addresses one of the fundamental challenges to getting a higher reimbursement for antibiotics, which is the fact that these drugs come onto the market with limited evidence about their value and truly a comparison or superiority to current standards of care. So to try to address both this volume-based problem as well as this issue around having adequate evidence that we need in order to evaluate the drug, we at Duke Margolis have been looking at ways to implement and how we might be able to use payment mechanisms in a more population-based approach to get higher reimbursement and bring better value to the field. So I first introduced this concept with our report a couple of years ago with the PAVE award, as Mark mentioned. We did have a transition from a market entry reward to a population-based payment. And we'd see that this population-based payment would be useful for providing sustainability, some transparency and predictability as to what revenues could be expected given the evidence adding up to the predicted value. So in our most recent work within this subscription payment model that I think we are calling a soft launch at this point in time, but we're trying to address this issue and trying to put together a framework for how we might be able to do a subscription or a licensing model similar to what's being done in the UK here in the US within the Medicare payment system. And just to kind of tie this back, this is something that we would see as being part of that incremental step. Maybe it's not a mechanism that can be implemented tomorrow, but with some of the changes that are occurring within the payment system, we think that there are incremental steps and approaches that can be used to get to the subscription payment that would potentially delink the reimbursement for antibiotics from volume to more of a value approach. So We think that there are several advantages to a population-based approach or to a subscription model, and this would include capturing that public health value within the payment that the antibiotic product receives. There's also the potential to continue data and evidence generation over time to better understand how we might be able to appropriately utilize the drugs, as well as what patient populations might benefit the most. And then alluding to what Michael said earlier, it would also provide the manufacturer and the who have the product more predictability around revenue. There'd be higher visibility around what revenue might be expected if a drug were to meet certain value elements. So this model is focused primarily within the Medicare space, and this is because, one, the Medicare patient populations are disproportionately impacted by bacterial infections, and Medicare ends up bearing the costs of a lot of these resistant infections in the form of increased utilization of services and hospitalizations. Medicare also has in place some authorities that allow them to pilot different alternative payment mechanisms, and so being able to take advantage of that approach to look at this from an experimental perspective where we are able to measure whether or not this alternative payment model or population-based model would be as impactful as we think. Potentially having something within the Medicare system would also allow commercial payers to understand how this could work and whether this would work within their systems, understanding that they have a more fragmented approach as they have different constituencies and different populations that they are covering under their different plans. So the basic framework and basic outline as we see it is that before product approval, CMS and FDA would work cooperatively to set some criteria and guidelines of what they'd view as a priority antibiotic and something that would be important to the US population health and potentially more global population health as well. So if a product or a candidate antibiotic were to meet these criteria, they would engage with CMS prior to approval to talk about what kind of outcomes or endpoints might be valuable to CMS and their patient populations. And so potentially these could be incorporated into the clinical trials prior to the product going onto the market. At approval, assuming that these conditions are met, the product would then enter into this subscription payment model. And a key component of how this would work is that there would be a formation of a third-party entity, which we're calling the Priority Antibiotic Manager, or a PAM, which would be selected by CMS through a competitive bidding process. So there could be one or multiple of these antibiotic managers, and they would be responsible for setting up the subscription contract with the antibiotic manufacturer for the product on a population-based basis, as well as having this manager interact with the providers. They would distribute the drugs to the providers, probably for a nominal fee so that it would be equivalent to generic, and they'd be able to maintain appropriate use and stewardship without having an unintended consequence of overuse. And the providers would give data around perhaps tracking or resistance and use back to the priority antibiotic manager, who would then use this, analyze this, report out on trends and the actual, what we see as value of the antibiotic. The payment for this antibiotic would probably be most difficult to implement at the beginning, in that part of it would be based on value and it would be harder with the evidence available. So we envision that perhaps, well, first off, this would be an advance payment, so this would be a recurring payment, not necessarily based on when the antibiotic is used. The base amount might be on expected use, and then have an added multiplier based on estimated value. And then as the antibiotic product is on the market, data collection would help to determine whether or not this value is playing out. And there'd be potential for adjusting the price either up if it's more valuable than anticipated, or potentially down if we see that this is not panning out as hoped. So we would have to have some key measures, which might revolve around costs to the hospital, could be around availability, the diversity of the antibiotic, whether it has a new class or a new mechanism. So these would be components that would need to be further worked out within the community. And obviously, there are limitations to this approach, especially around determining value. This is something that needs to be worked out, gathering stakeholder buy-in, and ultimately whether or not this approach would provide or add to the needed revenue and the needed return on investment for the manufacturers for it to be a valuable program in the future.
Great. Thanks for that overview. I just would say, connecting back to Michael's comments earlier, the NHSN, National Healthcare Safety Network data, which is really getting a lot better, is exactly the kind of data that would be needed to support and reinforce these kinds of additional value-based payment. I know, Nick, you're working on some of the same challenges, as you said, of expected value versus actual demonstrated value in the work in the UK. So that's Monica outlined as kind of a transition path. Nick talked about a transition path. Let me go back to Michael. So what you heard now, is Adjuvant going to switch over to immuno-oncology, or what's the next step?
Well, I think that one of the interesting things about the antibiotic space is, so as a global health investor, we kind of straddle two worlds, right? We have the traditional biotech pharma industry, which will find platforms in there that have applicability to global health indications. But then we'll also, look at smaller companies that are largely focused on global health type indications, or will work on a project finance with the global health division of a large pharma. One of the interesting things about antibiotics is that they kind of straddle these two worlds. If we're working with a traditional biotech company, we tend to play to those strengths. In that we can leverage the commercial opportunity of their more developed world products while getting them to work on activities of interest for us. Or if we're working with a global health entity, right, there's procurers in place, there's large donor networks, so on and so forth. So you actually have some visibility on market creation down the road, because you have entities such as Gavi that'll procure vaccines. Antibiotics really don't fit into either one of these at the moment, and as such, it creates this sort of big challenge in that you have some push for R&D, but you don't yet have a big procurement agency such as Gavi that can kind of de-risk these markets for you. And as such, I think that, I mentioned creating more visibility down the road. It doesn't have to be through a procurement agency, but through something such as a subscription model.
And if several of those are being done in multiple countries moving in the same direction, that would be a big help.
Exactly. And some of the dynamics that Monica spoke to earlier, as far as being able to flex up and down, I think actually make a lot of sense, because it allows for some level of differentiation for opportunity between these products. It'd be a much different story, I think, if every approved antibiotic meeting a certain level of criteria was paid in the same way. I think having some level of stratification within there gives investors, it allows them to gauge appetite for certain different projects and kind of weigh the risk return in different ways. So that's a long way of saying we have financed one antibiotic to date out of this fund. It was sort of in the former cases I mentioned, it's attached to a more traditional biotech company. So we actually don't really anticipate.
And what helped make that a good investment?
Yeah, absolutely. So, we're putting up development dollars that will go to advancing this platform more broadly, but that will also fund development of an antibiotic for, a neglected disease in Southeast Asia known as melioidosis. There is a PRV attached to that program, which we anticipate is providing some upside to our investment case. But the primary investment case for that one was not actually attached to that product itself. It's sitting inside a company that has other assets of value that we'd like to piggyback off of, so to speak. So, we have found ways to get creative to fund development of these products, but as far as, resting an entire commercial case on an antibiotic, that remains challenging in our view.
Yeah, and in terms of developing this sort of longer-term visibility into payment that better recognizes value, so we talked about the UK steps, we talked about the England steps, NHS steps, then we talked about the US steps. Suzanne, there are some other countries that are also moving in this direction. Maybe say a little bit more about that. In Norway, Australia, you're probably more familiar with these than I am.
Sure. I mean, a lot of discussion is happening within countries. We're aware of that. I mean, I think it's clear that, there's some real leadership here. I think the US, the UK are really taking the world along with the process, and that's not necessarily the case with other countries. So certainly some of the bigger European countries such as France, Germany, so to take Germany as an example, for example, they already have a DRG, DRGs that appropriate reward treating resistant patients. They already have the legal possibility to consider resistance when it's making its value assessments. They also have something called an NUB, which is the equivalent, I think, here of the NTAP, so a kind of signal of an innovative, highly needed technology as it enters the system that flags it for sort of special treatment. So there's a lot of stuff in place. I think one of the challenges that Germany faces is its evaluation system, its HTA system is built on clinical superiority. So quite how that mandate to incorporate resistance, we just have to sort of wait and see. So that's one example. Obviously, there's probably the biggest subscription model that has been implemented to date comes from Australia through their HCV. So that's another great example, a successful example actually of a subscription model. And Suri Moon wrote an article on this, which is well worth a read. I mean, that specific example wouldn't necessarily apply very well in this space. You probably wouldn't want a marginal cost, marginal price of zero for antibiotics for various stewardship reasons, for example. But so there's lots of activity, and I think what we're hoping to do this year is to start sort of bringing some of this to the surface and making sure that those conversations are happening as much as possible between countries and health systems.
Yeah, it does strike me that the dialogue is changing in this regard with more recognition and actual more steps, like in England, Norway, and some of the places that you mentioned, to try to implement these models, but still a lot of issues to work out in that direction.
Yeah, one of the interesting things when you're sort of taking the kind of crow's view, the broad view, is what you see in Europe, for example, is a lot of the innovation in this space actually often comes from the really small countries. Obviously, because they have the need, they don't have the bargaining power, they don't have the possibility of early entry necessarily. You know, these products don't come to their markets very early. So a lot of the innovation, at least in Europe, is actually happening from the small countries. And actually, what we hope that we might be able to do is take some of this more innovative thinking and try to convince some of the bigger countries to sort of open up.
And just to expand out on what's going on in the U.S. versus globally, since, as Michael's emphasizing, they're looking at global markets here, it does seem like there is a lot of progress also happening on the broader context of what Michael called the ends, not the means, of more appropriate antibiotic use and prevention of resistant infections through a whole set of reforms around infection control, stewardship of antibiotics, better tracking of resistance. That's certainly happening in the U.S. Michael, it sounds like that's also something that you're plugging into with this subscription work as well. Is that right?
Yeah, obviously, as part of the subscription model, we do need to make sure that the stewardship is really robust. But as I mentioned, there's a much broader AMR action plan in the UK than this specific piece of work that I'm talking about today. So the plan overall does include pretty much all of the sort of areas that Michael was talking about in the earlier session today.
Yeah, and again, if the focus really is on the end goal of controlling resistant infections, preventing their spread, preventing them in the first place, that comprehensive approach seems like it's going to continue to get more traction, and some of these other dimensions in some ways seem easier. And the U.S. has made a lot of progress, as Michael showed, in at least hospital-based stewardship in the last few years. We had a couple of questions in from participants on the web, including people who are innovating not in the antimicrobial, in the antibiotic space, but in the sort of prevention of resistant infection space, where these reforms seems like they would help as well. I guess one further push on this topic of pull incentives, sorry about that, is that if we do make a lot more progress in these other fronts in the near term, that by itself may make returns on priority antimicrobials even more challenging, right? Because if we're going to better stewardship systems in place. We're going to be doing more to prevent these infections in the first place. That does suggest that maybe some short-term steps, building on, you mentioned PRV or other sort of voucher or programs or these additional payments might be more needed, but maybe more compelling as part of this overall transition. Has those topics come up? That's kind of a long question, but I'm trying to put these payment incentives in both the short and the long-term context in which they're likely to be operating.
Yeah, no, I think these are all really important considerations. What's really clear to us in the UK is that obviously making the absolute most of the antimicrobials that we already have is essential. So in sort of avoiding a sort of an antimicrobial resistance crisis, really making our current agents last as long as possible and be as effective as possible is critical.
And it's pretty clear how to do that. We're just not doing it as opposed to
I think
the new antimicrobials.
I think good progress. I think good progress has been made in a lot of places, and I think Michael's talk earlier sort of illustrated that as well. But it's really clear that we're not going to be able to make the existing arsenal of antimicrobials last forever. There really does need to be new agents coming in. So I think it's just solving the problem is very multifaceted. Yeah. But sort of encouraging new agents to market has to be just one very important piece of the jigsaw.
Mm-hmm. And Suzanne and Monica, so any additional comments on prospects for, in the shorter term, additional payments on a volume basis for these priority antimicrobials while these systems continue to gain momentum and the details get worked out?
Yeah, I mean, I think the efforts towards a larger collaborative approach just have to continue. And I think in the meantime, while those discussions are ongoing, while that political momentum is hopefully rising, that countries are just looking at what they need to do at home, and they're not mutually exclusive. So,
yeah, I think just to add to that, I think the most promising short-term prospect for increased revenues would be through this disarm mechanism, or through other changes that could be made within CMS authorities as they are. But yes, I think that adding on with some of the data that we get from CDC, as well as what current health systems have, better utilizing that so it gets to the hospital sooner and perhaps works into these guidelines and determining where new antibiotics might be used most appropriately, if they can get onto the formulary faster, if they can get to patients faster that need them, that there is one way for a short-term fix to volume-based.
Yeah. So I want to open this up to a broader discussion with the group in just a minute, but one more question for Michael first. We're going to talk this afternoon. Kevin Otterson's been kind enough to, I guess I'll say this now, to share some pre-publication data and modeling around ROI for improved models of ROI on new antimicrobials. And one of the things that struck me about some of the new data, and maybe reflected in the experience of the couple of companies that you mentioned, is there are a lot of costs associated with just keeping an antibiotic on the market. So maintaining the manufacturing facility, doing the marketing. By that I don't mean advertising, but I just mean getting the product out on the market with numbers that are pretty large. Now, to your point earlier, this is where in the past, big pharma could potentially help because they've got a lot of established manufacturing capabilities, distribution, everything else. But if they're not in and they're not willing to get in, do you see any other alternatives emerging that could help maybe be an alternative way to bring down those manufacturing, distribution, sort of late stage sustainability costs? Because it's inefficient. It seems inefficient to do this like one company trying to do all of that themselves. That just doesn't seem sustainable at all.
Yeah, unfortunately, I would say absent. Unfortunately, I'd say absent some larger policy fix, such as we're talking here, it's very difficult without folding those programs into larger pharma platforms. right? One of the big beauties of pharmaceutical consolidation is you get leverage on all these manufacturing costs, operating costs, sales costs, et cetera. So, what we saw with Achaogen and Melinta this year is they have good drugs that got approved, but if you're burning $50 to $60 million a year just to keep them on formulary and keep the machine going, it's simply unsustainable at this point, is the truth. So, one of the things we would just love to see, and I know the whole space would love to see, is pharma open, or pharma's increased willingness, big pharma's increased willingness to start acquiring some of these programs again, because there are actually, economies of scale in these drug markets. We spend a good bit of time talking with our fellow investors at the Repair Fund, the Novo initiative that was set up, and something that we talk about a lot is the need for a new consolidator in the space. It doesn't have to be a large pharmaceutical company, but we do talk about over a 10-year horizon looking for, is there a logical platform, such as one of these already public companies or private companies, that makes sense to start folding these assets into? Because the more that you can have on a single platform, the higher the ROI you're going to have per asset.
Yeah, that seems like an important way to help bring down the cost too, and maybe an area where we can explore some further short-term incentives.
And one thing I'd add is it's sad to see the companies go bankrupt. That said, if these assets are ending up in the right hands, or they're not, for instance, in the hands of debtors, and they're just going to hold the IP and send it off, in the event that you can actually get some of these really low-priced assets into a single company.
Into a single company.
Yeah, that's right.
And then get what's left of that talent in manufacturing and distribution in one place.
Without mentioning names, we were in talks with one company, when Melinta was looking in late 2019, of starting an initiative like this. Things didn't come together, but there are people that are looking to try to make it happen.
So not quite there yet, but maybe another sort of interim step to help with getting to this long-term goal. Okay, great discussion. I would like to open this up to others here for questions and comments. Again, if you can go to the microphones and make sure everybody who's participating in the webcast can hear as well. And for those of you who are listening online, remember you can email us at amr.incentives@duke.edu with your question or comment. Yeah. Please. Is that on? Let's make sure you're... All right, technical difficulties, stand by one moment. I'm sure it's going to be a really good question.
No pressure.
Maybe we'll just go over, we'll definitely get time for you, but maybe go over here for now.
So, in the O'Neill report, there was this pay-to-play, which being from New Jersey strikes me as, something that's worthy of consideration. Also strikes me as fundamentally just. If you're making a product that's contingent upon the availability of antibiotics to treat infections or the prevention of infection, why shouldn't you be forced to, put some skin in the game with antibiotic development? But that doesn't seem to get much discussion after the O'Neill report. Is that an inviable approach?
So just to make sure everybody's following, so this was a proposal whereby basically the pharma manufacturers who are not in the antibiotic space would be paying a tax, which would go to fund something like a market entry reward, the kind of proposals we've talked about here, that could be short-term steps to help on the way to subscription models and this more ideal, outcome-oriented approach to preventing and managing antimicrobial resistance. Have not seen that talked about. Certainly nobody's backing that legislation in the United States that I know of. How's it going in England?
People have talked about such models, and again, I don't think any of these models are mutually exclusive. So if perhaps that's one more for the global hub to take forward.
That's the political hot potato.
Yeah. Yeah, go ahead.
So something to add here. I mean, it's certainly not at the scale, but there is a little bit of discussion. So I believe that Italy, for example, has a fund that pharmaceutical companies have to contribute to. and that creates a pool of money that they use to finance certain public health needs. Now, there is a discussion also in the Netherlands about a similar thing. There's a, but I can't speculate on the future of these.
So it sounds like it still is being discussed, at least in some places, but not yet, really taking hold. Vance?
Yeah, trying again here. Hey, Vance.
Yes, there you
go. From Duke. So my question really relates to who defines priority. Because in point of fact, it's very likely that what may be a priority agent in one place is not in another place. Furthermore, it's also important to realize that it's not just talking about, we're talking about trying to get more antibiotics. And that doesn't simply mean antibiotics that have a susceptibility profile against one of these resistant pathogens. It also means having antibiotics that treat susceptible pathogens better. And if you look at the MRSA example, there are a number of agents that are commercially available right now that frankly will treat patients better than what we're doing. But they're prohibitively expensive. And so as a result, clinicians end up using agents that are cheaper and more toxic or require an IV line and put patients at unnecessary risk to treat something that could arguably be addressed with a newer, more expensive agent for which there's less data. So I guess who would define that issue, what's priority?
And I don't know if any of you want to comment on that, and that picks up on, I know Michael's been involved from his comments this morning and approaches there. If any of our BARDA colleagues from the audience want to comment on that too, but anyone from the panel?
I mean, at a global level, I think it is one of the relative successes of the field is that WHO is making great strides in trying to signal what those priority needs are. Now, obviously, as a global organization, those needs are not necessarily going to match optimally for all countries, but at the global norm
but the principle
level, the principle
is gaining traction.
And you see that the priority pathogen list and the CDC list, they are, well, cause and effect, but they are shaping the pipeline. So these are at least concrete successes somehow.
Yeah, Monica?
And I think that this is a conversation that people have spent a lot of time discussing, and I think that is one of the more difficult things, is that one person's priority might not be as high as another person's priority. So I think that using some of the lists from CDC or the WHO are one, a good starting point. I think that having a diversity of mechanisms that an antibiotic can combat whatever pathogen, and then thinking about from the patient perspective what is going to be most beneficial to them and perhaps to the delivery system as a whole. So if having something that is maybe a longer lasting antibiotic, less adverse side effects for patients, perhaps having oral availability rather than needing to have an IV, would all be perhaps contribute to a profile that would define a priority antibiotic.
Yeah, this actually relates to a question, so I'm going to get to you all too, but since this is on topic, one of our web participants was asking about the same notion of basically saying, which sounds right to me, the estimated value of an antibiotic for AMR is a soft concept. Can we, do the speakers, do you all have any more views that you could elaborate on about what goes into this assessment or what should go into this assessment? And just picking up on Vance's question, one comment I'd add is that, like, in some sense, there are a lot of antibiotics out there that are in some sense priority antibiotics that are offering additional value that's not being reflected in payment mechanisms, and these efforts to focus the additional payments on a more limited set of designated priority antibiotics is kind of yeah, it's the right direction, but it's a principle that should be applied more broadly. And we don't yet have, Nick, it sounds like from your own experience, like sorting out what goes in, and Monica mentioned this too, you know, what goes into that value assessment and is not yet well worked out.
Yeah, I agree. It's not yet well worked out, but I think the ambitions that we've got for the sort of pilot program in England, I think it helps because you know, if we can really seriously try to capture the value from the different attributes of value, then the two different types of products that you sort of outlined, as long as we've got mechanisms whereby we can understand the two different value propositions and capture them properly, I think that will really help see the value irrespective of the nature of the sort of attributes of value. One of the things we're working through at the moment as well, and you know, and we did issue some draft papers a while back, is actually the sort of topic selection criteria for our for our pilots as well, and these are exactly the sort of issues that we're sort of aiming to address through that work.
It does seem like the more of these dimensions that you take account of, the more they really sort of bump up evaluation of an antibiotic for a population, the tougher it gets to fit that into a volume-based payment model, though, because these could be potentially large numbers tied to a small volume of use.
I think they could be, and they're probably going to be, whatever the magnitude of those numbers, they're probably also going to come with a lot of uncertainty around them as well. So I think when it comes to the sort of contracting, it's really important to be able to capture the different attributes of value, but it's also going to be important to understand the levels of uncertainty.
Make sure we're not way overshooting or undershooting
exactly.
with public spending. Yeah. Kevin. Oh, sorry. Neat.
I just wanted to follow up on Michael's remarks, the $50 to $60 million to basically stay alive at the initial phases once the product's been developed. And if you see a model like Civica RX as a non-profit biopharmaceutical as a possible transition partner, especially if there's a subscription model that would establish a long-term sort of demand and fixed price over time, or even sort of consideration of the ADMs, how they were designed to be sort of serve that model as a long-term manufacturing, maintaining stability in the manufacturing and the supply chain. So that's one question. The other is this idea of having to pick priorities. Michael, if you could comment, you mentioned your first fund was focused on vaccines, and in emerging infectious diseases, there's a lot of similar discussions going on who picks their priorities and which one, and it's not a priority until there's an outbreak in Wuhan or whatever it is. What about portfolio theory, where you could actually combine a portfolio of assets that would have some diversification, either in the antibiotics alone or in the antibiotics and the EIDs, vaccines and antibiotics, but have this diversification that you could sort of hedge that whatever the outbreak is, hopefully you would have that in your portfolio.
Yeah, thank you. So the first question on Civica, or if there's some way to have some sort of a procurement mechanism to bridge that early commercialization divide. There is a tool that's been used in vaccines by the Gates Foundation. It's a volume guarantee, right, whereby you have a big donor.
That's essentially what Civica is doing.
Yes,
it's like
exactly.
a long-term volume guarantee at a certain price. Yeah.
And so it's not something that we've seen. This is essentially whereby a big donor will ensure a certain amount of sales for a manufacturer every year to incentivize them to scale up manufacturing and enter one of the markets that we care about. I think that the big bottleneck there for that model is simply it's funding, right? You have to have a big donor with a big balance sheet in order to do something like that, right? Civica's been able to attract some level of funding to get this done for certain essential hospital drugs, but to do it for a whole portfolio of antibiotics, right? You've got to have a huge balance sheet in order to do that. And that's just
I think on top of that, the drugs where it's worked well for Civica are cancer drugs. drugs, drugs for treating serious acute problems in hospitalized patients right now, not drugs where a lot of the value is in some of these other dimensions that Nick and Monica and others, and we've all been talking about earlier, which go beyond just the value in that hospital stay. It does seem interesting of a way to sort of, if you want a payment to the establishment of that kind of entity. We're going to hear from hospitals later on in this in the meeting today, and try to get their take on some of this too. Yeah. Any other questions?
And then quickly on the second question, on creating a diverse portfolio of these assets. So, that really was the intention of our fund, and we are still nowhere large enough to create a diversified enough basket of assets to make portfolio theory such as that work. That's something that would really have to be done on a billions and billions of dollars scale, and we simply just don't have the scale to do it.
Great comment. Yes.
Hi, Patrick Holmes. I lead Pfizer's Innovation Policy Group and our AMR policy. And actually, the question online around value, it's kind of similar to where I wanted to go, but maybe I can go a little bit sharper into it. So I really appreciate the views on value this morning and the other types of value that need to be considered as part of antibiotics and some of the externalities and kind of the societal values. And it's good to see an aligned view across all the different markets, because I think that's something that we see as well. But I wanted to follow up with Nick maybe a little bit, because I think the UK actually is a bit farther ahead on this than other countries, and you're pretty close from what kind of we've seen around better capturing the value of antibiotics. But you said something in your talk about what success looks like in the UK, and it was something about a commercial, kind of successful commercial negotiation. So, and my understanding of that is this is basically taking what the NICE evaluation will look like and then getting that to a place where there's an agreement between a manufacturer and NHS England, the payer, about what a fair value is. So what is a successful commercial negotiation? Can you say a little bit more about what you think that looks like?
Sure.
And then we've got time for, if we do this one fairly quickly, got time for one from Kevin.
Yeah. I think a successful commercial negotiation would be that sort of informed by the NICE guidance, the company and NHS England both get to a place that they're sort of content with, really. I think that would...
And just to push on content, so content, at least as I've seen some of these negotiations work in the past, means there's going to be a nice estimate of sort of the value associated with the contract from the HTA that you're doing, and it's something that's in that ballpark, or?
Yeah, and I think we have to be realistic. Capturing the value across all of these different attributes of value is going to be very complex. And I think there'll be some dimensions of value where the estimates will be, reasonably secure. There'll be others where they become much, much more speculative. So what I envisage, and we haven't done it yet. So who knows where we'll actually get to. But what I envisage would be a really good HTA report from NICE that sort of captures the value, sometimes quantitatively, sometimes with relatively small error bars, other areas quantitatively but with very large error bars. There'll probably be some qualitative commentary in there as well. And that report will be the basis of a sort of a commercial negotiation, and it won't be me doing the commercial negotiations. That'll very much be the payer, NHS England, working with the company. But the evaluation from NICE will be a fundamental part of informing that commercial negotiation.
Great, thanks.
Thank you.
So my question actually follows on that. I see a lot of advantages, Kevin Outers from Boston University, see a lot of advantages to subscription models, but the disadvantage I see is that sometimes people refer to this as the Netflix model, and I'm afraid that they're going to want a $10 a month sort of fee, right? And the amount here needs to be substantial.
Well, if they get 10,000 antibiotics, maybe that's
if times 300 million people, maybe so, yes. But we only have in the U.S. out of the 16 most recently approved antibiotics that are still on patent, only 4 exceed $100 million of sales in the United States. And I don't know what Michael would say about peak year sales, but 100 million for the 4 most successful in a decade is really low.
That's not an immuno-oncology number.
He's shaking his head no. It's so we're looking for 3 or 4 or 5 or 600 million, And so the amount of a subscription, if it covered the United States, would have to be hundreds of millions of dollars, right? So we have to make sure that we understand that. We're not talking about a way to save money. It has to be a way to spend substantial amounts of money on a subscription.
Yes, I'd just really quickly say that's absolutely the way I would look at it. If you just do the quick math, VCs need to double their money every 5 years, essentially, to hit their target returns. If you're dumping, $100, $200 million into a development program, you're going to have to be able to sell that asset for at least a multiple of peak sales in the future. So I think the, $300 to $500 million a year number that you kind of referenced, that feels like a good starting point, but less than 100 a year is certainly not going to cut it from an investor's point of view.
Yeah, and boy, that really highlights the importance of Kevin's panel, where he's going to come up with the answers to this to this problem this afternoon. So everybody, stay tuned. More seriously, this highlights the importance of getting this right, from really understanding value and a willingness and ability, therefore, to pay more for effective antibiotics. But it does strike me that this is going to have to happen in the context of these broader shifts that we're seeing towards more attention to prevention, more attention to stewardship, more attention to an environment where it's not just going to be the antibiotic that we're paying for, but really better outcomes all around. So hopefully we can talk more about these steps in the afternoon. We're going to come back and hear on the delivery system side some of the things that are going on into which these incentives would be playing in, and then have that last panel where Kevin's going to give us the answer to the question he posed. But right now we're going to take a break for lunch. I wanted to thank our panelists for an excellent discussion on some really challenging and important issues. Thank you all very much. Okay, it's 1:03, so we're running 3 minutes late. I do want to give people time to eat, so we'll plan on starting at 1:50. Feel free to bring food back down here, and look forward to the afternoon sessions with you all. Thank you. Yeah, I think so.
Yeah, so I'd absolutely love to, because
All right, good afternoon, everyone. I'd like to welcome you back to our event today in our third session on exploring other actions that can contribute to a healthy antimicrobial ecosystem. In this session, we're going to move beyond the payment models directly, though somehow I think payment is going to continue to come up today, to talk about other aspects of care and issues that are related to payment that have the potential to lower costs of being on the market, to contribute to the evidence that we have available on resistance and on the appropriate use of drugs needed to address resistance, and again, picking up on the theme from the start of today about the progress and the steps that are happening in the overall ecosystem towards an emphasis on both prevention and stewardship, as well as support for antimicrobial development. So we're going to cover a number of those issues in this session. And I want you to keep in mind, as Kevin mentioned in the last session, the big numbers that might be needed for an effort focused on market entry support for new antimicrobials alone. I want you to think about that in the context of the larger environment, which is changing around incentives and supports for the appropriate use of antibiotics, as well as other steps to address the worrisome trends in antimicrobial resistance. So for this panel, very pleased to have with me Carla Miller, who's Vice President of Pharmacy Services and Clinical Therapeutics at HCA Healthcare, Samuel Peza, who's Senior Advisor for the Center for Value-Based Pharmacy Initiatives in the Center for High Value Healthcare at UPMC Insurance Services Division, Kevin Ronneberg, who's Vice President and Associate Medical Director for Health Initiatives at Health Partners, Sumi Saha, who's Senior Director of Advocacy at Premier, and Susan Van Meter, the Executive Director at AdvaMed DX. Once again, we're going to start off with some opening comments from our panelists and then turn to a broader discussion, which we hope you will participate, including those of you who are joining us on the web. We appreciate the comments and questions we've gotten in so far. So I'm going to start with Kevin. So Kevin, can maybe you could start by talking about what is being done now to ensure that beyond just reimbursement for a new antibiotic, that antibiotics are being used at the right time in the context of the larger steps that healthcare systems, systems like yours, are taking to deal appropriately with antimicrobial resistance.
Sure. Thank you, Mark. This has been a great day, and hopefully we can have a really good discussion here around some of the practicalities of the antibiotics. I'll just start by letting those of you that aren't familiar with Health Partners know a bit more about us. We're located in Minnesota. We have 3 different parts to our organization. One is that we are a health plan providing financing, and that's primarily in the 5 states in the upper Midwest, but have national coverage. Second piece is as a care delivery organization, where we have 8 hospitals from a level 1 trauma center all the way to 3 critical care access hospitals, and a little over 100 clinics, and I forget the number off the top of my head. And the third arm is around research and graduate medical education. What's unique about us is with the financing and care delivery, we are not completely vertically integrated. We overlap on individuals that use our financing and our care delivery by maybe 35 to 40% given the year. And that means that we're also having our health plan members use competing care delivery, and in our care delivery, we are accepting payment from other payers. So it's kind of a unique relationship that keeps us honest on a number of fronts. One of the things that we've talked about, and I know it's come up in one of the questions here, is around the total cost of care approach. One of the things that we've focused on for the last 20 years running and have developed a methodology for measurement of is total cost of care. And that's something that I think is an important component of this when we start to think about how it is that providers are paid, how health plans pay for coverage, and the considerations that show up that may either support what you're trying to accomplish with novel antibiotics or be a hindrance for that. Clearly in hospital settings, one of the drivers of their, and I'll step back, healthcare, as you know, it's a tough business, and so we're nonprofit. I didn't mention that. We seek to operate on about a 2 to 3% margin. There's not a whole lot of room for extra expenses. And so as we start thinking about how we provide care, we also need to be good stewards of our resources, not just antibiotics. Length of stay becomes extremely important in bed turnover. We don't have a lot of hospital beds given the population that we provide care to. And so with DRG payments and antibiotics, it came up earlier around MRSA treatment. And I think that one is a really good example where there's a newer agent that could be administered in maybe 2 doses rather than daily antibiotics for an extended period. And thinking about the value of that also is if you have someone that doesn't have a reliable home setting, or IV drug user, they're just not reliable to be coming back. That is a great way to treat the infection that they have and try and be a good steward of preventing the spread and perhaps colonization of others with that particular pathogen. With the current model in the DRG, and when we start thinking around total cost, if you're looking just through the lens of the hospital, you're saying for a much more expensive antibiotic given on the discharge day, we will blow all of the potential profit, if there was any, knowing that the CMS reimbursement and operating underneath CMS reimbursement is already extremely challenging, depending on which market you're in as well. So your choice is to say it's medically the right thing to do, it makes sense for this patient, and on the other hand, if this is the type of decision we make over and over again, we will go out of business. And so I think that's a really great example. And so the solutions to that get explored tend to exist in well, how do we discharge this individual? Perhaps they go into a long-term care facility where we can keep track of them and we can continue to administer the daily IV antibiotic. Well, that's an increased cost to the system and likely much more costly than if you were to use the novel antibiotic. The other way to think about it is we say, well, what if we could figure out how to discharge them and have them come back the next day to give them this drug as an outpatient? And the complexity that develops in that, the likelihood of them returning. And so I just share that as an example of some of the real world limitations that exist. I know with some of the NTAP reimbursement payments or add-on payments for some of the drugs, certainly solves for that limitation of the DRG and making sure that you can use resources wisely and also make sure you're not going out of business. It also, I was just having a conversation before this, it can reduce the incentive though, also to be really good stewards, both financially and from an antibiotic perspective of those particular drugs. And so there's always 2 sides to the coin on this. So it's certainly, I think, a step in the right direction, but it also opens up another potential opportunity that could create a situation we're not wanting. From a standpoint of, I wanted to address too the process, and I know others up here have expertise on this as well, the process of a novel antibiotic hitting the market. We've talked a lot about the financing, but the reality is your distribution channel, that drug needs to get into your distribution channel in the hospital and made available to clinicians who are considering that drug and prescribing it, and then it ultimately needs to be administered to the patient. And I think the reality right now is in a hospital setting, you're not only taking care of people with antimicrobial resistant organisms, you're taking care of a lot of other people. And this is competing against the resources for all those other people and all those other things you do. So a novel antibiotic shows up, and no one's necessarily been asking for it by name. And no one really knows how to use it. We've talked about guidelines are not updated on day 1 of launch. The ID specialists in that facility may not be familiar with it. They haven't had a chance to read about it, talk to colleagues, go to a conference. And so we know that it's probably not going to get used. And so our pharmacy teams and our medical groups make decisions to say, let's not spend our time and energy on that right now. And it gets set aside on a non-formulary status, waiting for someone to ask for it. And part of that is because we're trying to be good stewards also, and we have antibiotics that are serving a lot of the purposes we need. And so until someone says, we've kind of reached the limit of what we can do with what we have, it won't be addressed. because there's a whole process that takes a lot of time and a lot of individual effort to even get it on formulary, let alone some of the IT infrastructure, which I know will be addressed by someone else. I wanted to comment too on the stewardship piece briefly. I appreciated the discussion earlier from some of the reporting that's going on, and particularly the antibiotic utilization rates. And we've been reporting for a few years. I think the last I looked in the state of Minnesota, which is where I'm most familiar with it, 7% of hospitals were reporting. And so the numbers look great on the growth in that, but there's a long ways to go on participation and reporting. I talked to our pharmacy colleagues that lead our stewardship efforts, and kind of their blanket statement is, we're just really not quite sure what to do with it though. It gives us a data point and it tells us maybe how we're doing, but we're going to continue to do our stewardship work and we're going to continue to do the things we're doing. So it gives them, and we perform well. I think we're at about 80% of anticipated utilization, which is still within the brackets of not being underutilizers and hopefully being good stewards, but we don't know for sure. So it's just one data element. But we do feel strongly that good stewardship is not just a hospital-based imperative. It applies to our emergency departments, it applies to our surgical centers, to our infusion centers, and ultimately to our ambulatory care clinics where 75 to 80% of antibiotics are prescribed. And so I think that the one thing that we recognize is that you think of the bathtub and you can't just address the spigot or the drain. It's really got to be both. We need to try and stem the tide of developing resistance while at the same time working on the novel antibiotics. And I think using some of the work we're doing with novel antibiotics to drive the stewardship components, and even more broadly than just hospital settings, is an opportunity that shouldn't be wasted. So I'll just stop there.
Thanks very much. Thanks very much for the comments, Kevin. So next I'd like to turn to Samuel. You've also got some experiences in an integrated system and the payment side too at UPMC. I mean, you could add to this discussion about how to think about the challenges of AMR and how a health system, especially a health system that's moving in this direction of population health, total cost of care, as Kevin mentioned, is thinking about all this.
All right, thanks so much for the opportunity to add to all these discussions. And so just as a background, UPMC is a very large integrated delivery and financing system, meaning that we are both a provider and also a payer. We have over 40 hospitals, we have over 700 physician offices, and we have the health plan, so I work more with the health plan side of things. And we have about 3.5 million members. And out of that, about 1.5 of them have the pharmacy benefits as well. And so I'll speak more from the system perspective. So our setup helps us to be able to look at value in a different light because we have access to data on everything, right? So we have the medical side of things and we have the pharmacy side of things. So when we mention value, most of the times we are trying to see any innovative product that comes out. Obviously, the pharmacy cost is going to be high. And so my center is charged with looking at it and seeing how does the medical side hopefully is going in the opposite direction. And so how does the medical side balance out the higher cost from the pharmacy side. And so based on this, apart from before I go more into those payment models, UPMC is a nonprofit, just like Kevin mentioned, but we also have a for-profit wing where we call it the UPMC Enterprise. And just 2 days ago, they announced that they are investing $1 billion over the next 4 years. And they are going to invest in life sciences. And so they have medical devices, medical diagnostics, and even drug developments. So they're going to give several funding and collaborations with startups in the next 4 years. And that's an exciting part. So that's somehow our contribution to the push side of the incentive equation. But when it comes to the the pool side, we have not shied away from very expensive products. In fact, we have entered into several value-based contracts with several manufacturers, which we consider to be a win-win situation because it gives access to some of these innovative products to our patients, and somehow it helps manufacturers because they somehow get good tier in our formulary, which has been great. So what we normally do is to follow all these outcomes, and then again to see whether it's aligning with what the real-world data is showing is aligning with what pharma has done. So in that sense, we are almost providing incentives for manufacturers to know that if a new product comes, there is a system in place where you can have access to that. But that balances it with the antimicrobial stewardship wing of things. Because all the incentives that we are talking about today is driven more by how much is manufacturers going to make, which is often driven by price and utilization, right? So if antimicrobial stewardship is going to reduce the number of people who potentially could use the product, then you have to look up to cost. And that's where payers always struggle, because if the cost is going to be high, already the budget is at this limit, and so it makes it a challenge. But the good thing is that we often depend a lot on our providers when it comes to any of these new antimicrobials or any innovative product that comes onto the market. And so once they come out to say it's a very important piece that needs to be on our formulary, most of the times we go for it because we're able to assess it at the system level. And I'm proud to say that the UPMC Presbyterian was recently designated as the Antibiotic Stewardship Center of Excellence by the Infectious Disease Society of America. And it's all because they've combined everything with innovation. So they have a center for innovative antimicrobial therapy. And they boast that a maximum of 4 hours, they'll be able to find out the best antibiotic to use for any given patient. And so that has driven a lot of the things that they do. And in addition to that, we are currently going to run a project with CDC on antibiotic stewardship across all our hospitals, which is also going to be an exciting thing. So I think I'll pause here, and then we'll take it from there.
Great. Thanks very much, Samuel. Appreciate those comments, too. So you picked up on, again, taking this systematic approach, recurrent theme we're hearing today on the importance of timely diagnostics, and 4 hours is pretty impressive. You can reliably do that. I don't think that's a national standard, and in many cases, I think we don't have the kind of diagnostics we'd like. And I'd like to turn next to Susan. So clearly, a good part of this comprehensive response is knowing the right antibiotic to use timely on a particular patient. How are we doing with the diagnostics in the hospital setting, and maybe more generally as a contributor to these this progress in AMR?
Great. Well, I'm very pleased to be here today to bring diagnostics into discussion.
And one thing with the microphones are like really directional, so kind of point it right at yeah.
Great. Okay.
Yeah.
Yes, that is better. Thank you. So, so I'm Susan Van Meter. I'm the executive director of AdvaMed DX, and AdvaMed DX is a trade association that represents about 70 manufacturers of in vitro diagnostic tests and technologies. And we represent these companies in the U.S. and globally. So our reach into trying to work to address AMR does go beyond the borders of the U.S. And really appreciate a lot of the comments from the prior panels on the nature of the problem and the need to think really broadly about how to address AMR, certainly through encouraging the development of new microbials, antimicrobials, but also, I commend our colleagues from health systems here for the good work that you're doing on stewardship to really try to address how is it can we diagnose more accurately, faster, and then act upon those diagnostics in a way that ensures, to Mark's point, that the right patient is getting the right antibiotic at the right time. And in some cases, that those diagnostics allow clinicians to have the confidence to de-escalate antibiotics when they are also not necessary. So really commend you for the work that you're doing. So out of the 70 companies that we represent, there are a large number of them that are heavily involved in the effort to combat antimicrobial resistance. And our efforts take on many different forms, from working with our colleagues at IDSA, for example, and other specialty societies to encourage the more rapid updating of guidelines, to strong partnership with the CDC. We have made a commitment to the CDC's Global AMR Challenge and appreciate the CDC's leadership, particularly in the area of educating clinicians about how to more appropriately prescribe antibiotics. So there are any number of facets that we're focused on: reimbursement to ensure its appropriateness, coverage as well is certainly an area of focus. But I'm going to highlight one particular area, and that is diagnostic stewardship. We took a very practical approach over the last year for a number of reasons. Our colleagues, Samuel has mentioned that your hospital is at IDSA, Hospital of Excellence. There's an antimicrobial stewardship program that the IDSA has established, and we commend them for their work and their leadership to really go beyond the CDC's core elements. And we understand from IDSA their interest in diagnostic stewardship. Pew, CDC, many of our colleagues here are interested in diagnostic stewardship as a way to ensure that we're fully leveraging the diagnostic tools and tests that are available to bolster and strengthen antimicrobial stewardship programs. So we began the work in the inpatient setting as a practical matter and developed, again, over the last year, a series of concrete recommendations that we have offered to public and private sector partners as practical ways to, again, more fully leverage diagnostics to ensure effective stewardship. And I'll just give one example that is in our recommendations. For antimicrobial stewardship programs, there is always a leadership team, and we encourage that included in that team are laboratorians to really bring the expertise of the laboratory into the provision of care, bring them closer to patient care. Another recommendation that we have is to really take a very concrete look at key timeframes. The 4 hours of getting a real clear indication of what that microbe is that is infecting a patient, that is phenomenally fast and terrific. Now think about what happens if the results of that test are sitting in the EMR and not acted upon. Right? So we have a set of recommendations that sort of break down key timeframes and encourage, through use of your EMR, to actually really look concretely at what those timeframes are, measure them, and assess what can you do to shrink those timeframes, because that's tremendously meaningful for patients. Every hour counts when you're thinking about sepsis, for example. And we are moving now into developing ambulatory diagnostic stewardship recommendations. Appreciate the CDC's leadership in this area recently in particular, because I think in the ambulatory realm is where we really need to do a much more concrete job of assisting providers, prescribers, and more appropriately prescribing antibiotics. Sometimes that means using a diagnostic test and trusting the results. I often give a statistic I find tremendously compelling that our colleagues at CDC have published, that in ambulatory settings, 30% of patients who test positive for flu still walk out of that clinician's office with a prescription for antibiotics. Mm-hmm. So there is a lot of education to be done, and we are hoping through this work on diagnostic stewardship to really, in a practical way, help support our public and private sector partners in combating AMR.
Great. Thanks very much for those comments. And next, I'd like to turn to Shomi. And Shomi, your organization helps providers with stewardship, with purchasing, so very much aligned with some of the topics we've talked about so far. Where do you see some of the opportunities for improving antibiotic use? And I'm going to tie that back to the incentives as well. Yeah.
Great. Thank you, Mark, and thank you, everyone. So Premier is an organization that unites an alliance of about 4,000 hospitals across the country, as well as about 175,000 non-acute providers. We are widely known for our leadership in the supply chain world, but equally impressive is how we really leverage data analytics and our ability to test and scale learnings through collaboratives to really identify how we improve healthcare while also lowering overall healthcare costs throughout the country. So I'm going to focus my comments today on three main areas. One is how Premier has been leveraging clinical surveillance tools to really drive data to action. Two, the potential to leverage clinical decision support tools and electronic prior authorization to really elevate access to the appropriate antibiotics at the right time. And then third, ensuring that we maintain access to older generic antibiotics in this space. So what we know, and point number one regarding clinical surveillance, what we know is that establishing an antimicrobial stewardship program and electronic surveillance are two known methods of improving AMR. So what Premier did several years ago was launched a clinical surveillance tool. It's something that we refer to as Theradoc. It's currently implemented in over 1,000 hospitals across the country. And what this does is it pulls and leverages data from the electronic health record and surveys the data and provides real-time alerts to clinicians to determine, is the patient on that right drug? And to points we heard earlier, it also helps identify whether or not you need to de-escalate or discontinue therapy because there is a drug-bug mismatch. It also looks at adverse events and looks at the totality of what else the patient is on and looking for those drug-drug interactions. Also provides alerts as far as when can we switch from an IV formulation to an oral formulation. Also looks at redundancy in treatment. How do we switch patients to narrower or less expensive therapies? And then also, interestingly, a couple of things that were mentioned earlier today that this does is, one, it provides a one-click reporting mechanism to the CDC NHSN program, so really incentivizes and makes that much easier for hospitals to be reporting into that program. And it also provides modeling for clinicians to utilize to determine what is the appropriate dose to get a patient into the appropriate treatment window as soon as possible and keep them there. So that really helps, get that patient to a treatment place sooner, quicker, et cetera. So we've seen some great results with this over the years. So just a few statistics when we look at single hospitals or single health systems. One system saw a 27% reduction in median time to appropriate therapy. Another saw reduced odds of infection-related mortality by 76%. One system saw a reduced length of stay by 2 days, whereas others saw a 286% improvement in appropriate prescription of antibiotics. Now we have to talk about dollars as well, because one of the things that we're always looking at is how do we reduce overall healthcare costs. So some other key numbers from, again, single systems or single hospitals. One system saw a $1.5 million incremental cost savings in their first year alone, where another saw about a $250,000 difference just in interventions. So what do we do with those results from single hospitals and health systems? Well, at Premier, we create a national collaborative. We test and scale those across the country. So we created a nationwide collaborative where we worked with over 500 hospitals, and we focused in on C. difficile. And since 2015, we're proud to say that we, through our collaboratives, have reduced the rate of C. diff infections by more than 46% across those 500 hospitals. That translates to about a $27 million of savings since 2015. So that is just one example of how we've been successful in bringing data, technology, analytics, and subject matter expertise together in that collaborative manner to really speed performance improvement and continually raise the bar in healthcare. So a big question that's often raised is, what about the VA system? So Theradoc in the past few years has been piloted in 3 of the VA medical systems in West Virginia, Baltimore, and Washington, D.C. The data there speaks numbers as well. So in just the past few years, the VA in those 3 centers alone has seen a $2.3 million savings in just those 2 years. And they increased their number of pharmacy interventions prompted by the Theradoc system from about 3,000 to over 10,000 in those 2 years. So if we were able to scale what these 3 VAs did system-wide the potential for savings and improved outcomes for veterans across the country could be considerable. So let's move on to point number 2. How do we use clinical decision support tools and electronic prior authorization? So one area of technology that we really think can be leveraged in the fight against AMR is clinical decision support, such as Stanson Health. This uses artificial intelligence and is embedded directly into the EHR, providing real-time patient-specific best practices. This is where we can really leverage diagnostic stewardship, for example, and how we can leverage new guidelines and really encourage working alongside those guidelines and early adoption of those guidelines because of how CDS really works. We really think that another element of clinical decision support that really needs to be evaluated is electronic prior authorization. So when there is a broader spectrum antibiotic or a novel antibiotic that needs to be used, how do we expedite that prior authorization process in a real-time electronic manner so that we are minimizing the time between prescribing and that first dose of medication for the patient? The other thing we would love to see CDS and EPA potentially play a role in is those NTAP payments. We hear often from our member hospitals that the process for submitting for an NTAP payment is so cumbersome and so laborious that they often forgo it. So is there a way that we can leverage technology to automate that payment system and work with CMS to really streamline that and modernize it and leverage technology in that space? Now, one key element to really leveraging CDS and EPA is we need to address the barriers to interfacing with EHRs. So my third point regarding generic older antibiotics. So shifting gears slightly from the technology aspect here, we think another area that really warrants attention in this space is around drug shortages. So several older generic injectable drugs have been on the drug shortage list for years. Think penicillin, erythromycin, ceftriaxone, and we really need to figure out how we ensure these products are available for patient use, because if they are not, and if we are forced to use a broader antibiotic where something narrower should have worked for that patient, we are not only encouraging AMR, we're also increasing healthcare costs throughout the country. So this is where Premier, through our Provide GX subsidiary, is working with manufacturers to create the incentives that they need to continuously ensure that these products are available for patient use and to ensure that you have the right drug at the right time for the right patient, for the right microbe. So with that, I'll close here, but just wanted to thank you guys again and looking forward to the Q&A.
Great. Thanks, Shumi. And just one clarifying question on this last point about the generic purchasing. So is that done through sort of the Premier as a group purchaser ability to get these systems to work together to commit to kind of a long-term contract for providing the generic
so
antibiotic?
Provide GX was launched. We're coming up on our 1-year anniversary, so in February of 2019. And it works in a couple different ways. And what's unique and different about this approach versus what Premier has done in the past with drug shortages is that it really allows us to, one, provide committed volume to manufacturers over an extended period of time, providing them the confidence that they need to enter the marketplace for these products, because they often do have a very low ROI associated with them, unfortunately. And then two, it allows Premier to co-invest alongside these manufacturers and help alleviate some of the financial burden associated with bringing these drugs to market. Again, very high cost drugs, talking the injectable market space, but also because that low ROI really allows us to use unique contracting mechanisms and different mechanisms to incentivize manufacturing of these products.
Great. Thank you. So, Carl, I'd like to maybe help put together some of these comments. So you come from provider pharmacy kind of background. Based on what you've heard, anything you'd like to add, and also what do you see as the greatest challenges in this space, and what's HCA doing to address them?
Great, thank you, Mark, and really excited to be with this great panel today. First of all, let me talk a little bit about what HCA Healthcare is, and then I'm going to spend some time talking about our foundational antibiotic stewardship program across the organization, the health system. I want to spend some time talking about where we're focusing in 2020, and then how we're taking that across the continuum of care. So HCA is 185 hospitals, 120 ambulatory surgery centers. We have freestanding emergency departments, urgent cares, physician practices, robust GME program. We're across 21 states in the U.S., and we have some hospitals in the U.K. as well. So just to give you an idea of utilization of antibiotics in the system and a little bit about the system, HCA had over 30 million patient encounters in 2019. So of which 8.9 of those were in the emergency department setting, over 2 million inpatient encounters. And looking at these inpatients, 43% of inpatients receive an antibiotic during their length of stay. And across the hospitals themselves, greater than 9 million antibiotics administered. So we're looking at a lot of data, and that allows us to be able to really drill down into what that data and what that use looks like. So talking about the foundational program at HCA, I think it's important to establish our corporate division and facility teams are all comprised of an interdisciplinary team whose goal is patient outcomes, patient safety, lab being a very important critical partner on those teams, as well as infection prevention, physicians, not only infectious disease physicians, but also our emergency physicians and our general practice physicians, and nursing, pharmacy, et cetera. So we have these teams across the organization, and wanted to start when we're thinking about stewardship in a health system. The first thing we've touched on formulary. Kevin mentioned formulary and the process there. So a new drug comes to the market and it's evaluated based on the current evidence in the market. And unfortunately, we know that oftentimes when a drug enters the market, the evidence is not robust. So decisions are often made on the limited evidence that that drug was approved with. So formulary decisions are made. That trickles down to the division level, the facility level. Guidelines are put in place for how that medication is going to be used in the process. I think it's important to note here, during that process, there's also a consideration of one, what do the guidelines say? When were they last updated? Two, how are we going to embed that in the order sets today? And in the electronic health record, while we've had many advances, we know that's not an easy process. Not an easy process to build a new drug into the system, ensure that's mapped across the organization. Adding drugs to order sets is not an easy task. And putting it in the order set where the appropriate place where it would be in the appropriate utilization stream. So next, we also leverage clinical decision support. So building that clinical decision support to really assist in that appropriate ordering of that antibiotic, not only from what the utilization, what organism we're going after, but also what's the duration of therapy going to look like. Also in the background is, if you're starting on IV, the background of when is that going to be transitioned over to an oral medication, when that's appropriate. One of the areas that we have spent quite a bit of time over the past few years is partnering with Harvard on a research study titled Inspire, and it's really looking at smart prompts. And what we're doing there is taking patient demographic information and tying it to the risk factors of multi-drug resistant organisms and guiding the practitioner ordering that medication to make a decision that's going to lead them to a narrow spectrum of activity to decrease the overutilization, even in the empiric setting of these antibiotics. So the electronic health record is extremely important when you're talking about appropriate use of antibiotics. It's absolutely foundational to our antibiotic stewardship program, but it's not easy. It took us over a year, once we decided what the smart prompt was going to look like, to get that built into the system. So then thinking about once a patient is on an antibiotic, that constant monitoring, we were just talking about surveillance, and we have also implemented a real-time surveillance program across the organization. And that's making sure you've got accurate, timely, streamlined use of antimicrobials, ensuring that when that lab test result comes back, that someone is notified in order to make a decision. And that is a metric that we follow closely, is time to action. That way we can find out where our gaps are and how do we narrow that window. Because once you get that result back, you want to make a change as absolutely soon as possible. And leveraging data is key when we're talking about the system we have. We do have the luxury of having a lot of great data and a very robust clinical data warehouse. And that allows us to develop enterprise-wide dashboards where we're constantly monitoring these type of process and outcome measures to see where do we have opportunities for improvement. And when I talk about this enterprise dashboard, I can't not talk about the great partnership with CDC. We've been sending data, utilization and resistance data to the CDC for a few years now, and we're really starting to understand or get our mind around. Kevin, and you said you guys are looking at this well. Is how do you use that standardized antimicrobial administration ratio? In 2020, shifting gears to what we're doing now, one of the areas that we are going to devote quite a bit of time is trying to get at the unit level to be able to look across the organization. An example of this is we're really drilling down into pediatrics right now. And we're looking at the NICUs across the organization and doing some comparisons with that SAR across those PICUs, across our organizations and the NICUs. So we're really excited in this partnership with CDC and really getting that data out there so we can better understand what our utilization looks like. And as Kevin mentioned, it's a fine line between underuse, overuse, inappropriate use. So ensuring that you're in that perfect window. Other areas as we go into 2020, lab is a huge focus. The diagnostic stewardship, how do we optimize procalcitonin when we're choosing antimicrobials? How do we optimize our cultures in the emergency room? And how do we ensure that patients are being treated appropriately? Standardizing our C. diff testing, optimizing MRSA testing, really looking for a lot of partnerships in the lab space. And then we're also looking at expanding the SMART prompts with the INSPIRE study because the preliminary results have been extremely positive. So that takes us into, and I've spent a lot of time talking about what we're doing in the hospital, the walls of our hospital emergency department, but it doesn't stop there. We do have many physician practices and urgent cares, and what we're doing there is trying to leverage our data in order to monitor what those practice patterns look like, get that information to the provider. We have over 200 affiliated GME programs, so ensuring that residency training has a key component of antimicrobial stewardship, appropriate use. And then we're also talking about how do you provide more robust clinical decision support in that outpatient setting as well. And I think, once again, the challenge there being developing it in these EMRs. And we do have the luxury of a majority of our hospitals share the same electronic health record on the hospital side, but in the physician practice side, it's a much more diverse group of EMRs. So either trying to figure out, do we bolt something on top of those to develop clinical decision support, or do we partner with each of those EMRs to develop really decision support at the time of prescribing? So those are some of the things that we're working on right now. Really, I think key is multifaceted approach, wanting to ensure that we are doing what's right for the patient at the end of the day.
Great. Thank you. Thanks very much, Carla, for those comments, and all of you. So I heard a lot. It's really impressive what's going on and the trajectory that you're on. I heard a lot about real progress and reforms in stewardship and surveillance with attention to appropriate prescribing based on guidelines, and attention to evidence of impact and continuous improvement. I didn't hear much about NTAP and additional payments for new antibiotics, except in passing from Show Me, which is basically to say, gosh, I wish it was like easier to automatically get payment for this. Are these payments not relevant? Or can you say something more about how NTAP and some of the steps that are in place now and then building on them, like this arm, that have been proposed in the short term to address the development of better antimicrobials plays in or doesn't?
I think Mark's looking at me.
I can don't take it personally.
No. See, that's on, okay. I couldn't shut it off. So, yeah, the NTAP payments, or add-on payments, DRG carve-out, I think they serve an important purpose on helping when there's a decision to be made, address some of the economic inputs into that. So when there is a newer, more expensive agent, what we don't want is we don't want individuals to be making more of a purely economic decision. And so having an additional payment that helps cover the cost of that drug or that medication without, I'm using the terms that I've heard from a few people, blow up our DRG. I think that helps from a standpoint of us using drugs in the right way. So as long as it's the right drug for the right person, the right time, and I like adding for the right microbe, it plays a really important role. I think there's a legitimate discussion around when it doesn't apply to much of what you do on a daily basis in a hospital setting. There's a risk of not knowing how to do it right, doing it incorrectly, forgetting about it. And that's just the practical side of it. That's not a reason to not do it. But I think that's one of the realities that as a system, anytime there's a new rule or a new way of getting reimbursed, a new prior authorization, on and on and on, somebody has to be addressing that, understanding it, following up on it to make sure it was submitted correctly, that they're paid for it. And then I think there still is the unknown. I mentioned briefly earlier that as we start to have NTAP type payments, where you're kind of bypassing the impact of a DRG or the effect of a DRG, what's the unknown consequence of that? I think certainly making adjustments to the DRG seems to make a lot of sense where appropriate, so you're still living within an expected cost to drive good use of resources. And so I think we're going to have to wrestle with that and learn as we go with it.
Mm-hmm. Okay, so I see not, and you want to add something,
No,
Shilani,
I don't
or?
really have much to add. I mean, I would say that what we often hear from our hospitals is they would love to have the NTAP reimbursement. They do think it'd be beneficial, and it does help offset blowing up the DRG, if you will. But the process right now is so cumbersome, and you have to, behind the scenes, connect the dots. It's, the old school days of faxing prescriptions and faxing prior authorizations. Papers get lost. And so there has to be a way that we can streamline and modernize that, because one of our goals at Premier is to ensure that our hospitals and healthcare providers receive appropriate reimbursement for the care that they do deliver. And so we think that's a critical factor that needs to be addressed.
Okay. And I did hear from...
Can I just add? I think the other real thing, I'll go back to the challenge of operating a healthcare system under some of the reimbursement rates. And, if we're at 75% of the cost, you're already taking a challenging DRG from a resource use perspective, and you're helping with using the right antibiotic, but you're also saying, we're only going to pay you for a portion of it. And I think that's a really tough conversation in today's world.
Yeah. So what I did hear a lot about, and I take the points about what might make NTAP work better. What I did hear a lot about was attention to recent CDC initiatives and this general, I think because it fits into this general strategy of you're trying to do value for your patients, and the IT systems are getting better, the ability to support evidence-based guideline treatment are getting better. you all are not representative organizations in terms of the extent to which clinical decision support, real-time surveillance, data integration using AI and so forth are being integrated into supporting the delivery of care. How widespread is that approach now? How fast is that going to become more widespread to other institutions, to your ambulatory settings, et cetera?
I'll start the conversation. I think in looking at the electronic medical record space, there's still technology is still slowing us down from making progress. It's not that we don't know how we would want this clinical decision to be built. It's not that we don't have proven data that shows that clinical decision support can impact, change, and lead providers in the right path on evidence-based guidelines. It really is partially due to the technology available today. So I think it's going to take some time. It's going to take some time partnering with health systems and the electronic health record organizations to develop that type of decision support. And then taking decision support to the next level. So there's the basic rules, and then there's more smart rules that's collecting data on that patient and guiding the decision more than just patient meets 3 criteria, now can move from an IV to an oral agent, to this patient is coming in from a home environment, risk of an MDRO is extremely low, signs indicate an infection, antibiotics needs to be started, but based on the risk factors for MDRO, this patient's a relatively low risk, so let's recommend to the prescriber going more narrow on their empiric treatment. And I think that type of decision support is very complex, and many of the electronic health records and EMRs just aren't built to support that type of complexity.
Yeah. And just to push on this a little bit more, are there further policy steps that could help accelerate moving in this direction? Kevin emphasized that you've only got limited resources, so keeping there are all kinds of patients coming in, keeping all kinds of guidelines up to date, dealing with these interoperability issues, expanding the rules and so forth. Is this something where, as was suggested this morning, maybe an additional push from CMS or payers around getting with the evidence-based guidelines could help? Is it an area where accelerating the updating of guidelines, if there were sort of faster IDSA or other supported efforts to recognize the role of new antibiotics and adjust, are those things that could help? What would move us down this road better? It does seem like we're moving down this road.
I'll just jump in briefly. I think on the issue of updating guidelines, and it's tough work. It takes a long time to do that, but it's a very fruitful effort. So I appreciate Carla's comments about when HCA is looking at creating maybe a rule, for example, you look and see what are the guidelines and how dated are they? Because that matters a lot. When I think about diagnostics and innovation in the diagnostic space, there are plenty of times where there is a new innovative diagnostic that, for example, can cut the amount of time inpatient or even in ambulatory settings with new rapid tests to a diagnosis to set that patient on the appropriate care pathway, but there's not a widespread understanding that those diagnostic tools or tests exist. And part of the reason is because if the guidelines are out of date, then perhaps there's no mention of that new technology. So I think updating the guidelines, or at least having a mechanism to have sort of interim recommendations. When the whole of the guideline can't be updated, what can we do as an interim step to flag key pieces of information? Maybe they're gleaned from a CDC surveillance tool, maybe it's about new technology, can help inform providers' decision-making.
Mm-hmm. So what about mandatory reporting on CDC recommended guidelines and mandatory contributions to CDC tracking of antimicrobial resistance and use patterns?
I'll jump in here. So I think mandatory reporting is difficult if it can't be automated. It is very difficult to ask a provider to stop, or any healthcare individual to stop what they're doing and remember the 30,000 different mandatory reports that they have to file on a daily basis, depending upon their patient care population. We have to find a way to be able to automate that and to streamline those processes. I think it's a great idea in theory, but we have to be able to operationalize it to make it fruitful.
And would take some work, just like you were saying earlier, with respect to the reimbursement, to get this integrated with EMR. Sounds like potentially an interesting item for the to-do list. I'd like to open this up again to discussion from those who are here. Any questions and comments from online as well, please let us know. Robert. And please let them know who you are in case they don't know. Oh, so it's Robert Horn. So yeah, and go. And I think now you're on.
I talk loud enough anyway. So
there you go.
Number one is just given the recent attention that CMS has given to the issue of stewardship and NTAP, I'm wondering if the hospital systems on the panel have considered this an appropriate time maybe to identify ways to improve NTAP and share those with CMS. Some conversations that we've had, I think that might be a very receptive message if given to them. And then number two is maybe, and then I'll stop. CBO did measure a couple of years ago during Cures the impact or the benefit of stewardship on savings and found zero. But what you all just described a little bit, the interaction of stewardship and protocols and CDS and prior auth may be a model to identify new savings. And I'm thinking of the radiology example with CDS. And so on both those topics, I just love some feedback. And if any data or protocols for how you use those types of things would be available for people that maybe wanted to test the savings. Thank you.
I can start us out with question number one. From a feedback on the CMS NTAP, we have worked closely with Federation of American Hospitals to provide feedback on that. And I would agree, setting it up in the back end is a very manual process. And once again, we have the luxury of having a large regs and billing team that does a lot of that work, which is manual, on the back end for the system, so it takes the burden off of the individual facility. But that is definitely an area of discussion of optimizing what is in the NTAP, but second, making it easier to be done electronically. Second question was related to CDS and cost savings, and we're hoping with the recent study we're doing with Harvard, we can prove out. We definitely have a proof of CDS leading to savings, but I think with this formalized research study, it will be easier to show than just a retrospective analysis. So we're hoping that's going to be one of the secondary outcome measures.
Okay. Other comments? I see some nodding there. Good. Thank you.
So I'll speak as a clinician, sort of the other end of the system, and I have 2 points to make. One, in the stewardship space, in the laboratory space, when you're running programs, I cannot overemphasize enough how it's all about the money. And that's what we get from the system. So the University of Pittsburgh Medical Center, and it's great to meet Samuel, who I apparently work with, and you have to go to national meetings to meet people at your own place. University of Pittsburgh will never say you can't bring a new antibiotic that you're going to champion for onto formulary. They'll never tell you can't use it in an individual patient or you can't use it in 100 patients. When my boss, Huang Win, though, meets with leadership every year on the stewardship end, they don't talk about the center of excellence. They don't talk about the 4-hour diagnostic turnaround time. They talk about our pharmacy budget. And if she wants a new pharmacist, she has to come up with $120,000 of salary and benefit support out of pharmacy savings to justify every person she brings onto stewardship. So those are the realities. And this is the financial pressure that companies have to realize that the clinicians and programs are under. It's not that we're saying you can't use omnicefin as much as you want, but at the end of the year, you're running that program, you're evaluated on the dollars. And anything you expand, you've got to come up with the dollars. And I think Kevin made an extremely important point, is that formulary time is a real ramp-up time. And you look at the time it takes to get new products into hospitals. And that's all down to local champions. I could be a champion, I'd get anything into the University of Pittsburgh, but I've got to champion that. I've got to do the work of making the case up front of how we're going to pay for it and how it's going to improve outcomes. And then I've got to bring you the metrics in a year and show you that I did it. And on top of everything else you have to do clinically, that's a heavy lift. And you can do it for 1 or 2 or 3 things a year. You can't do it for 100 things. You can't do it for everything you'd want to do it for. And you can't do it for every discipline in the hospital. We're 1 out of 15 medical disciplines. So these are the realities. Clinicians would love to do all this stuff, but you got to pick your spots and pick your battles.
Any comments at the?
So I just want to follow up on the heavy lift piece. And, one of the things that could be an opportunity, I'm guessing that, HCA and UPMC have similar experiences, but every hospital historically kind of has their own process and needs to do it themselves, right? So the work you talk about championing to get a drug on formulary, in a consolidated system, it's realistic that work could go on several times for several different hospitals. And when you have competing systems in the same community, that work is duplicative. And all of the work to collect evidence and create a monograph around safety and quality, et cetera, that's also a place where maybe there's an opportunity beyond just whatever non-inferiority study was used to achieve FDA approval. So a lot of work and a lot of resources that I'm guessing if we could come up with some sort of way and a trusted resource to update and evaluate these drugs for consideration on formulary and take that work off of each individual system or each individual hospital to do lit searches, there might be value to that. I see you standing up.
Well, wait, let me get a little bit more comments in. Samuel, were you going to say something on this? And I have a follow-up, and then we'll come back.
Yes, I just wanted to say that I think that's where innovation takes a lot of the heavy lifting, because that's one thing that UPMC has done. They've invested a lot into innovative approach. So they are thinking once you're able to use like up to the 4 hours to tell exactly what needs to be done, it cuts off a lot in the guesswork, and then it saves a lot of money up front. And so I think that's we've seen cases where our hospitals are doing better than the ones that are not in our system, because we have a lot more leverage over our own hospitals than the others.
Okay. Well, I wanted to kind of follow up on this with, if it is the economics, and several in the follow-up have talked about, sort of blowing up the DRG, then that would suggest an increased payment, like an increase in TAP or something like this ARM could be helpful. On the other hand, Kevin also emphasized, actually all of you emphasized, that where you're really driving is for your institutional strategy, and where it seems like a large part of the country is headed with CDC initiatives and CMS conditions of participation and so forth, is this more comprehensive view of appropriate prescribing, appropriate surveillance, paying some attention to total cost too. And Kevin brought up, boy, it'd be nice if we didn't all have to sort of duplicate the same work on how to implement those kinds of systems. How could you align an additional payment like a disarm or something? It was just like an additional payment for the antibiotic. That doesn't seem like it fits well. On the other hand, if it did fit in with sort of being tied to guideline use or some other steps that would address the concern raised about, are we actually following sort of the best evidence-based practice? Does that make sense as a way of addressing some of this potential conflict or making progress? And if so, maybe someone could state more clearly what I just said. Anybody want to try?
Let me try.
Okay.
I think it's an interesting concept of, I think the key there is, okay, we're going to give additional payment for antibiotic utilization, antibiotic, but ensuring that it's being used appropriately so you don't have a perverse incentive. So
you've got to be, participating
right,
in the CDC program,
participate,
and
or you have to use a national approved order set that comes from IDSA or some type of, I don't know if we'll ever get to the point where our providers would sign off on one order set. We can't get one hospital's barely signed off on one order set. You all could. But if we had some type of guidelines that had to be embedded into an order said that you could tie appropriate use, I think that is definitely interesting. And echoing Kevin, even we have a corporate development arm for formulary guidance, but in addition, that corporate goes to a division committee, which makes changes, then goes to the facility, which adds changes. So still, you're talking about 185 different iterations, plus the corporate one, plus the 13 divisions. So you're absolutely correct. If we could somehow get to a standard.
Any other final thoughts before we wrap up about how to proceed? I mean, it is impressive how much, at least in your organizations, we're moving in the direction of attention to and support for through IT, decision and clinical decision support, AI, and other tools, more evidence-based practice in this area. You're finding measurable impacts. Still a long way to go, but it does seem like further incentives related to new antimicrobials really needs to fit into that big picture trend.
And if I could offer just one other idea too, as we're talking about how can we ensure that these new antimicrobials that we are hoping are coming to market and that will have a significant expense to them are used appropriately, I would suggest a diagnostic, right? I mean, we have companion diagnostics, like very clearly in the oncology space. It's something that we're very interested in, our members are very interested in, but a really important concrete way to really help clinicians ensure that they're making the right choice for their patient.
Great, thank you. All right, well, I want to thank all of our panelists for an excellent discussion. We're going to pick up on these ideas for where to go next. That's actually kind of the title of the next session. Right now, we're going to take a short break, and if you all want to, maybe since we're running a couple of minutes ahead, maybe we could aim to start again at 3:10. Promise to get you all out a little bit earlier, but still enough time to take a little break. Thanks again to our panelists. Come on up. Yeah, close enough, right? All right, welcome back this afternoon for our final session, modestly titled Next Steps and Reflection on the Path Forward. You all have heard a number of really interesting perspectives in the discussion today around trends in the ecosystem for addressing the growing burden of antimicrobial resistance on the health of Americans and population health worldwide. This session intends to build on some of those ideas and issues we discussed with the goal of identifying both shorter term and steps and longer term feasible goals for addressing this challenge, including legislative, administrative, individual stakeholder actions, and any other good ideas. So we've got a diverse set of panel perspectives joining me on the stage for this session. Kevin Otterson is the executive director of CARB-X. Jeremy Knox is a policy and advocacy lead for the Drug Resistant Infections Program at Wellcome Trust. Brenda Honeycutt is the Director of Regulatory Innovation at Faster Cures, and Robert Horn is the founder of Forest Hill Consulting, has also been working in this space of public-private collaboration for some time. So thank you all for the time and effort to be here and for paying attention and contributing during the course of the day today as well. And I'd like to start with Kevin. So we've heard Kevin, about some of the shifts that are taking place with increased capacity around supporting CDC goals on appropriate infection prevention and surveillance, tracking, as well as stewardship, including reliance on guidelines. We've also heard that the economic incentives behind the use of antibiotics, including new antibiotics, matters a lot, but in terms of getting to practical ways to address the disincentives for using and developing appropriate antibiotics, we're probably not there yet, even though we're in a changing environment. I know you've been doing some recent work updating some previous work around return on investment and thinking quantitatively about the steps that are needed. So we thought it'd be good for you to start off this discussion to the extent that you can connect that kind of modeling and economic assessment with the issues that we've talked about today. It'd be a great way to kick off this discussion about next steps. So I'll turn to you right now.
Right, and I don't know if the slides are available. You didn't ask for slides, but I brought them anyway. I'm sorry about that. Yeah. So, I took a look at a presentation from 2009 on this topic, and a question leapt out. How much should we pay for these, economic incentives for antibiotics? And I thought, oh my goodness, we're still, a decade later, we don't know really the answer to that. And so, I wanted to do some work that actually would advance that so that all these clever ideas, whatever we land on, we have a sense of the economic size that they would need to be. And standard disclaimers, I'm speaking now as a professor at Boston University, and all the results are tentative, and I intend to publish it peer-reviewed, so please don't mess up what the publisher is going to want to do eventually. But this is my objective, so that everyone in any conceivable room would agree with the data inputs into this model and the structure of the model, and therefore right, left, and center, U.S., Europe, everyone would begin to have a consensus on what the correct numbers should be. It turns out that for a lot of the parameters there's strong agreement. For a few there's not, and we can do sensitivity testing to show the gaps in those. So I'll tell you a little bit about the project. It's built on the Eastern Research Group 2014 study, which I was a participant on, that was done for ASPR FDA. It uses that model, but then updates the parameters, the data inputs into it, only in a transparent way and only in a way in which I can defend a change. ERG had no hidden data. All the assumptions were explicit. We're going to continue the same process here on this one, and I'm going to release part of it to folks who agree to sign a data use agreement with me to prevent publication before I do. to give a chance for a larger body of people to critique and tell me the parts of it that I've gotten wrong. There'll be a model and it'll be linked to a dashboard. And I'm going to show you a little bit of the dashboard in a moment because that's what will allow us to change a few of the assumptions and see how it affects the answer. And so everyone can get more comfortable with how that works. So I've talked about this process already a little bit, but these are examples of some departures. So ERG inflation was higher. It used an 11% cost of capital, expected internal rate of return. Today, 10% is a more reasonable number. The actual cost data in ERG was drawn from the year 2012, updated that for inflation using the NIH biomedical inflation adjustment tool, et cetera. Each of these will be described fully in the paper and defended to the best degree possible, but these are the types of modifications and changes from the Eastern Research Group model that'll be made. This work, there's been a lot of people that have helped me, but it's entirely a product in which I've made the decisions on. There's no financial support. I'm doing it as a professor at BU. There's nobody who's paying for this work, and haven't worked out yet who really wants to contribute to the extent of writing the manuscript and being co-authors. No decisions on that yet. You can't do anything in this space without abbreviations, but I just wanted to give them to you up front. But the important ones that you may not use all day is probability of technical and regulatory success, so the chance that a project that's in preclinical is going to make it all the way to actual FDA approval, and how is that expressed in a percentage term. And then the other key one here would be the peak year sales of the drug. We've talked about this already. The rest of them, you probably have seen before. I know you can't read this, but this is what the actual model page looks like, and it enables you at the top through a drop-down menu to select how big the peak year sales are, how much when you start the project, what year you started in, and how much preclinical cost sharing there is, and then you click the button and it calculates the market entry reward that's required to hit the indicated cost of capital that you have. And so this is the thing that will be part of the publication. The full Excel spreadsheet will be released. For folks who want to help me and sign a data use agreement, I'm going to give you the model and allow you to play with it, find problems, find mistakes, critique it so that it can be the best possible thing, so that it's transparent when it's published, that people have had a chance to attack it and to get it to the best possible shape. But the goal is that you can choose these parameters, the level of preclinical services, preclinical cost sharing, so how many push incentives are happening, the chance of success, how risky or not risky are the projects, the peak year sales, because the assumptions there matter a lot, and then you change any of those and you can calculate what the market entry reward amount should be, and vice versa. Whichever parameter you leave out, if you fill the other ones in, you can calculate it. And that gives you a chance to play around with it and to see what the ranges are. Also, it should note that it calculates that for an expected internal rate of return of 10%, which is the target. It's what large pharma would like. 0%, which would be even more nonprofit than every nonprofit hospital in the United States, and then 5%, kind of an intermediary sort of calculation. All right. So I've got 3 result slides to show you. This first one, it shows the market entry reward necessary in order to achieve a 10% expected internal rate of return. And then there's 2 rows there. The first is BCG and the second is ERG. The difference between those probabilities of technical and regulatory success reflect that the BCG numbers are slightly more pessimistic. They think that there's a lower chance of success at each stage, whereas the ERG numbers showed a slightly higher chance of success at each stage. I'm in the process of validating both of these with our actual experience at CARB-X, but haven't gotten to that point yet. So that's the difference there. And you can see it makes about a 25% difference depending on which estimates you use on how successful projects are as they go forward. I want to put a proviso. Both of these numbers are kind of current systems focused. And at CARB-X, at least, we're trying to choose riskier projects, first in class, crazy things that have never been approved by the FDA. Most people think the probability of technical and regulatory success for such things is lower than the average, right? Which would make the requirement of a market entry reward higher. And then the 2 columns, one is with 75% preclinical, so a lot of push incentives, And the next column was with no push incentives, no preclinical cost share. So the two takeaways here, the push incentives really make a huge difference in the size of, it doubles if you don't have push incentives. And that, the estimates of the probability of technical regulatory success make a difference. It's about a 25 to 30% difference. It's not as huge as the change from preclinical. Second output slide. Okay. Don't know what I'm doing differently now.
Yeah, it was working before.
It was working before. So maybe our helpful, the battery decided at this moment to die. Is there somebody who can advance the slide for me in the back? I need. All right. Yeah, I don't know what I'm doing differently. He's got a magic touch down there. So for the record, Robert Horn is rubbing the battery. And it's going to work. Do you want to? Yeah, I don't know what to do with that.
That's why we had him on the panel.
So the second sample output here shows if you have $200 million of peak year sales versus $400 million, and remember, in the comments earlier, we only have 4 drugs out of the last 16 approved by the FDA in antibiotics that exceeds $100 million in U.S. sales. So $200 million is kind of a stretch. That's a dream, but $400 million is a big dream. So you might think $400 million if we got everything that people are asking for in terms of disarm and the 2021 IPPS rule and some other Christmas ornaments as well. To get to that number would require some change. But you can see that as the peak year sales go up, even at $400 million, still a very significant market entry reward is still required. And then the last one, what if you had a lower target? If you were not shooting for 10%, so you're not large pharma anymore, but you're somebody else for whom 5% is a good number. The numbers do get smaller, but still in the $200 million column, you still have a $1 billion, a number that starts in a B. And maybe if you magically got to 400 million, which would be quite the stretch in the current environment, you still have a significant number, but not a $1 billion number. So, got like 2 slides, and I don't want to give this to Robert once more. Really? Okay. So the last thing I want to say is that it's my intent to, if you're an academic or somebody who enjoys doing technical reviews of Excel economic models and would like to help after signing a data use agreement, then you can send me your email and I'll share a locked version of it and you'll be able to look at it and give some commentary back. The goal here is to be writing this manuscript in the second quarter of this year and to have it published sometime late in the year 2020. So hopefully this will all be out in the public domain and be able to be discussed after the election.
Great. Thank you. Do we still need Robert to keep at it? We're just gonna move on. All right, Jeremy, you don't have any slides, but you have had an opportunity to see and hear a lot of what's going on in this space, antimicrobial resistance, not only here in the U.S. but worldwide. What stuck out? What would you like to focus on in terms of path for next steps based on what you've heard today?
No, thank you, Mark. And it's really good to have a chance to be here today. And it always reminds me of just how bafflingly complex the US healthcare system is compared to someone who's grown up with the relative simplicity of a national health service in the UK. So I think kind of really the kind of thing that shines through thinking about what's been going on over the past few years, and I think the kind of the backdrop to all of this is that the success in achieving the type of kind of major reimbursement reform that I think many of us have been optimistic about, many of us have been pushing for a number of years, has remained kind of fairly underwhelming, and the need for that manifestly, as Kevin's slides have just shown, has manifestly not gone away, but it remains an issue where I think that the progress is really kind of perilously slow, and that we kind of can't afford anymore to bank entirely on that type of approach to deliver the sort of stabilization kind of and strengthening to the R&D ecosystem for antibiotics that we know we all need. But I think what the conversation is today, and that the work that that Mark and his team have been doing now for just over kind of nearly 2 years really does show is that there is promising progress being made, particularly here in the US, on the kind of a range of incremental things that can be done to improve the reimbursement landscape for antibiotics. The kind of the complexity of the system in which we work and the complexity of the system in which antibiotics are used obviously means that there have been this range of things that are depressing the value of antibiotics, limiting their use, and often kind of going against even good stewardship goals. And I think the kind of the dialogue that we've been seeing about how to unpick these things, how to kind of remove the downward pressure on pricing, I think is tremendously important and tremendously encouraging. And I think on the one hand, it's not going to deliver any silver bullets. It's not going to deliver the type of kind of big bang reimbursement reform that we all hope for. And of course, it's very difficult to do this in a complex healthcare system, particularly where you're trying to make the case for something that has been cheap and kind of reliable to become much more expensive. That's pushing uphill. But really, we shouldn't kind of discount actually the fact that these sorts of things can and hopefully will play an important part in taking us some way towards providing kind of a more sustainable and more secure ecosystem for antibiotic R&D in the short to medium term. But there are still things that we kind of that need to be done beyond this. There's still a kind of range of fronts that we can be acting on, and that we, from Wellcome Trust perspective, are kind of keen to see progressed in the coming months, years, and over the short term, while we kind of continue the longer term progress towards more major reimbursement reform. And there's a couple of kind of key things that I wanted to focus on or reflect on today. Firstly, I think is the internationalization of what we've been hearing about here. Inevitably, for better or worse, the US healthcare system is the only one which can really kind of single-handedly move the globalized R&D markets in pharmaceuticals. The kind of the politics of that question is another debate, but it's important. It's kind of important to focus on the US healthcare system because it can deliver some sort of global stimulus to the R&D landscape. But that's not to say we shouldn't be looking at how we can also kind of bring these sorts of things to bear, these sorts of kind of incremental improvements in reimbursement to bear in the kind of the wider range of global markets that can have an effect and can incrementally kind of build the business case for commercially led R&D in antibiotics. And I think when I look at the landscape as someone who is obviously based in the UK, spends a lot of time US facing, but also it tries to be kind of international in our outlook, I think it remains the case that the US, along with certainly the UK and a couple of other countries, is really kind of out on a limb in terms of the leadership on AMR in its broader sense. And Michael's presentation this morning kind of really gave a very good flavour of just how much the US is leading by example across the world. And I think when we look at the different landscape, we heard a bit this morning around how some other countries are grappling with this. We've heard from Nick about the UK model, but there's still a lot more to do in terms of really kind of convincing governments in other key markets. And when I talk about key markets, I mean not just kind of the key European markets, but also potentially middle-income markets, which are often overlooked, but are potentially hugely lucrative from the antibiotics perspective, or hugely kind of significant from an antibiotics perspective. There's a long way to go in terms of really convincing governments to start taking these sorts of steps in their healthcare systems and really kind of addressing the reimbursement challenges, the valuation challenges, the kind of the technical challenges that could make antibiotics a kind of a more favorable and more justifiable commercial prospect in those markets. I think kind of US government leadership is important and is being maintained on that front, just like the UK government's leadership is. But I think there's a lot more from a civil society perspective and from a kind of industry perspective that we can do to make sure that other governments are stepping up and following the example of those countries that have taken the lead. The second thing I'd say is that from from a funder's perspective, we kind of really do want to think about how we work with a research community, think about how we work and interact with companies who are active in this space, and think about what we can do really on the kind of the supply side in the R&D space to kind of improve the commercial equation around antibiotic R&D. And that this will yield, we think, significant benefits regardless of what happens on the reimbursement side. And when I talk about this, I mean it's about trying to identify ways that we can make the R&D landscape for antibiotics more efficient. How can we identify the kind of economies of scale, the synergies that I think Michael talked about this morning, to really kind of make sure that we go from a position where we have at the moment kind of a lot of great early stage R&D being done in kind of very small, very promising biotechs. How can we kind of take that small scale R&D into a much more efficient landscape in the late stage? And that might be about using kind of big pharma as partners, but it might also be about taking alternative approaches to kind of bring assets together, identify the synergies, identify the economies of scale. And we're really open to looking at how we can do that, looking about how we can do that in a safe and sustainable way that works for kind of the various different actors, whether they be private sector actors or others, and really try and kind of work out how that can play a potentially kind of game-changing, we think, role in terms of the overall stability of the R&D ecosystem. So kind of thinking about kind of the conclusion and ultimately where this leaves us, I think we remain kind of optimistic about many things we see, but really kind of still acutely concerned about the overall state of the R&D ecosystem for antibiotics and kind of its long-term prospects. When we have companies kind of operating on a practically kind of month-by-month, hand-to-mouth basis, that's really not a sustainable or a comfortable position for us. And from Wellcome's perspective as an organisation that cares very deeply about this particular area, and as an organisation that has invested very considerably in this area, that's kind of really something that causes us to figuratively, if not literally, kind of lose sleep at night. So we really do want to kind of be pushing on a number of fronts, pushing internationally, pushing in key markets like the US, maintaining the push towards long-term goals, long-term sustainability, but also trying to kind of find as many of the kind of the accumulation of incremental marginal gains that we possibly can to get things onto a more sustainable footing. The only alternative to that we see is one that really we don't want to countenance. It's kind of seeing this continuing kind of domino effect of companies with promising products going into kind of increasingly uncertain kind of economic territory. From our perspective, that's really kind of not one that we can countenance. It's too unpredictable, it's too uncertain for patients who need these new products. It's too troubling for funders like ourselves who kind of face the challenge and the kind of temptation to getting into the space of trying to do bailouts. And ultimately, it's kind of too much damage to the kind of the ecosystem, to the type of expertise, the type of talent that we have in this space and really need to maintain in this space if we're going to have a sustainable space over the long term. I'll pause there, but look forward to picking this up.
Yeah, a lot to come back to there, Jeremy. Thank you very much for those wide-ranging comments. So, Brenda, at Faster Cure is an organization that both focuses on innovation and focuses on doing it from a patient perspective. I'm wondering if you see, given the particular strengths of Faster Cure, some opportunities for addressing some of these challenges.
Yeah, thanks, Mark. I appreciate that. And I just wanted to kind of introduce ourselves because I feel like we're probably one of the newest members of the AMR community. So I wanted to mention kind of why we're interested and why we're committed to helping find solutions to combat AMR. So Faster Cures is a nonprofit, nonpartisan think tank center of the Milken Institute, which believes in the power of capital markets to solve urgent social and economic challenges to improve lives. So our Faster Cures mission is to accelerate medical research and bring treatments to patients. And like Mark said, we're not a patient organization per se, but we keep patients at the forefront of everything we do. So the fact that new antibiotics are not making it to patients falls squarely within our mission. And we started by committing to the CDC's AMR Challenge, which we heard a little bit about this morning. And during the last year, we've used our Milken Institute events platform to raise awareness of AMR and convene global leaders to connect people and continue the discussions to advance some solutions. And we'll continue to do that this year. We have a number of private and public sessions planned for a number of events events throughout the year. But we wanted to do more. We wanted to add some programmatic work on this topic. So we've talked to experts, and thank you for everyone in the room who we've talked to so far, and we'd love to continue to talk to people. And kind of two areas floated up to the top, given our unique value and expertise and community, that we think we can really leverage our work in communities to do. And one is in activating a patient community around AMR. And I'll talk a little bit more about what we're planning on doing this year. And the second is to leverage our reach into the investor and finance community through our full Milken Institute to design new funding models to support new antibiotic development and access that we can partner to pilot and really try these things out. And I'll talk briefly about that as well. So in terms of the patient engagement work, what we'd like to do this year is really go out and talk to our expansive community of patient organizations, in addition to the AMR stakeholders and people around this room. So first, we really just want to identify what the challenges to mobilizing patients in this space are. You know, why is it not happening, or that we haven't seen it yet in a coordinated fashion? So from our discussion so far, we know that there are initiatives to collect individual patient stories, bio, IDSA, and others globally. And individual patient advocates are out there as well, for sure. But we haven't seen any indication of groups that really tried, or maybe there were groups that tried to set this up, and we want to understand what happened to them, or if they haven't been developed, why not? You know, clearly there are unique aspects about AMR in the way that it's seen and treated, particularly that patients don't really think of themselves in an AMR patient group. Like, that has very little meaning, I think, at this point. So we really want to just take a landscape, see what's out there, what exists, what patient organizations are talking about AMR, what are they saying, are they prioritizing that in advocacy in any way or not, and really what are the barriers there. And then in another thing, when talking to people, you know, that can increase awareness of our intent to mobilize patients, and really talk about what current patient organizations' interests are, to contribute to some sort of collective action that we might develop and stand up. You know, there are groups of patients that might be more dependent on antibiotics. This might already be on their radar. I know that Cystic Fibrosis Foundation already funds new antibiotics and many, many other things, so that's clearly on their radar. Sepsis, transplant, chemotherapy, patients undergoing chemotherapy. But we also want to be very broad in our reach. You know, we've been thinking about past those kind of maybe more obvious patient groups. We have a very large community of patient groups across diseases that we'd love to talk to, because clearly AMR affects everyone, will affect everyone, and we want to get that message out as well. And even broader past patients, you know, I was thinking the other day about AARP. Maybe that's a group that has that would have some interest here and some power in an advocacy sense and an education sense and beyond. And then another thought would be that for the initiatives already going on to collect patient stories, while we talk to people, we can certainly ask, you know, for additional patient stories to try to bring these patient stories together. And then, you know, we'll explore what might be the best way to activate patients and build a patient community around AMR, whether it's partnering with people already doing PR campaigns, whether it's creating a coalition of existing groups, whether it seems to be to create a new research advocacy organization, or maybe it's simply Faster Cures or someone else or partnership that can support already existing communities and give a platform or a space for these organizations to come together, learn from each other, and work on this topic in a more kind of coordinated and directed way. And we can use this to identify any lessons learned from prior attempts or what other organizations are seeing out there. And maybe there are other kind of similar contexts where patient or there have been organizations that bring patients together that don't, that wouldn't associate with themselves as a patient. I think maybe of joint replacements. I think there's a group that started a registry for joint replacements. We could kind of look to them, and maybe they have similar kind of learnings that we can learn from. And then we want to develop a roadmap, right? So everything that we, before I get to the roadmap, I think we need to really articulate clearly what we want to accomplish by this, by mobilizing patients. So, as Faster Cures, we certainly believe that patients are expert in their experience, and they should be at the table in healthcare decision-making and R&D decisions, and their perspectives and needs, goals, and insights should be considered across healthcare. But we want to make sure and be thoughtful about what are we actually trying to do and how do we know that it's working when we actually try to do it. So we'll take all of this together, and the plan is to develop a strategic implementation plan of what we think should be done, and then to do it. So whether that's us, whether that's partnering with a group of other people, whether that's just providing a platform where existing partners can come in, but we want to have something that really moves the needle and really delivers this voice that, from talking to people, it does seem like it's absent, or not absent, I shouldn't say that. It's not to the strength that it could be. It's not to the coordinated strength. So that's on the patient voice side. Then the other thing that that we're hopeful to do this year, and I'm not a finance person, so I might throw out a couple finance words, but I don't really know much past that. So I can connect you to someone who does, but that would not be me. But regarding this idea of designing new funding models, so the Milken Institute has a model called the Financial Innovation Lab, and that's basically a structure that we use to develop viable models and policy recommendations to drive investment and accelerate the development and commercialization, in this case, of new antibiotic candidates. So these programs usually tackle specific financing gaps or market failures where the requirement of blending public and private capital come into play. We first conduct a landscape to understand the barriers to investment and identify a couple promising financial models that might work in the particular context that we're looking at, and then we bring together a diverse set of finance leaders and content specialists to really vet these ideas and ultimately design one that we can go ahead and try to implement, something that really is feasible in terms of being able to pilot it. And then something else we've heard, a need exists for a community of investors who understand the unique landscape of AMR and antibiotic development. And this, our hope would be that this could certainly contribute to that as well. And I'll stop there.
Brenda, thanks very much for those comments. And so turn to Robert. You also do a lot of work across the public and private sectors, working with legislators and others. Where do you see some of the greatest opportunities here?
Mark, thank you. First off, I think one of a good opportunity is, frankly, Faster Cures joining this effort. I've seen their work, and I've seen big pieces of legislation get off across the finish line because of that work. So we should talk afterward, because it would be great. I think from an opportunity standpoint, I just want to echo maybe some of the comments that folks have made today, that it really looks like from the U.S. side that a lot of opportunity exists this year. I think we've talked about CMS opportunities. We've talked about ASPR and BARDA's increasing commitment, I think, to this issue. We've talked about a number of different issues, CDC and others, that have been leading the way for a long time. And I really do hope 2020 is a year of opportunity. A couple of thoughts on that, I think. From a CMS standpoint, we'll look at the potential of IPPS 21 happening in April or May. That's opportunity number one. I think there are opportunities potentially on the Hill to look at appropriations and new funding, and I want to talk about that a second, some of the barriers that currently exist to that. But really, I think across the spectrum, one of the things that has helped us recently, I hate to say it this way, really is some of the difficulties that companies like Melinta have run into. It really is serving as a canary in the coal mine, and we're really starting to see policymakers respond. And so we do expect some congressional engagement. We do expect letters maybe to the administration shortly. We're hearing some of that now about what the plan is, and certainly all of the ingredients there about a well-defined problem and a potential market failure does hold some promise for this year. One of the things I do want to touch on really quickly, though, is ways that we can maybe help increase the chances of success in 2020. And one of the things that's difficult here in Washington, D.C. is the politics of spending. And I think everybody understands that a little bit. I don't think this is a U.S. problem alone, but when politicians are looking at an issue, they want to know what the spending requirements will be, and then they look at the politics related to that spending. Here in the U.S., the spending and the politics of spending in part are how much is it, and we have to offset it. And so areas, I think, where we can identify funding sources outside of the USG and almost think of them as down payments, the easier it might be to get politicians in the U.S. To fill in the remaining. And one of the areas that Jeremy touched on really is ways that the international community can help a little bit. And one of the areas that we've been considering, and I've talked to Kevin a little bit about this as well, is really ways that countries can collaborate together, not necessarily through a G7 or a G20 or WHO, but certainly using those as opportunities. And the parallel the parallel coordination almost might come out through contracts that individual companies, or individual countries, pardon me, all may get into with individual companies. As people have talked about the Global Fund a little bit, and this is really kind of where I'm going, people have identified the potential of foreign funds to help. They've also, I have been in conversations where people have identified some of the downsides to the Global Fund perspective. And one of the downsides really is the politics of spending. Why do I want to give my money to a third party for the purposes of global good when I can get some of that at home? And so some of the thinkings are, if we can encourage the same type of global community that a global fund has, but empower countries to establish their own contracts, identify their own ways to fund it, a subscription model, direct appropriations, a tax. Leave it to the individual companies to decide where those funds come from. But in such ways, we do think that the individual contracting approach, and again, if 5 countries work together, they all write the same contract, maybe with some regional differences, but they agree on the key criteria ahead of time. What are we going to prioritize? How much are we going to spend? What portions come out of the contributing countries? These are ways in which we are hoping that the global community might be able to work together and get past the roadblock of how do I justify to my constituents, to my voters, that giving dollars to somebody else is going to directly benefit us. So I'll stop there. And in general, I really have been impressed, I think, with the level of thinking in this room today, and I've heard a number of really new and unique ideas. And my hope is that we can carry some of this momentum through today and into success this year.
All right. Well, let's see. Great comments from everyone. I'm going to see if I can keep both with, on the one hand, this is a really hard problem that's been pretty intractable, especially on the pull incentive side. On the other hand, some reasons, if not for optimism, at least for moving forward. So I'm going to try to keep that spirit alive as we go through the rest of this discussion. We'll see how it goes. What was it? 1.6 billion per? Yeah. Yeah, I'm not going to try to get your slide back up there. But let me start with a legislative proposal that is getting a lot of attention here, and that's disarm. And maybe try to reformulate my poorly phrased question from the last session after hearing all of the impressive work that has taken place over the last few years in developing system support, IT, AI, data sharing. I mean, we're not there yet, but compared to where we were 5 years ago, much more attention to a comprehensive approach to AMR, to addressing AMR that includes infection reduction, includes appropriate use of guidelines, includes tracking resistance, sharing a lot of the data with the CDC. Admittedly, it's not what we heard today is not representative of the whole country. Was it 7%? The other Kevin said in Minnesota, but a number that's growing pretty rapidly. Also needs to extend to the outpatient setting. But that seems like a pretty clear, established trend that's in line with a whole bunch of U.S. policies around more data and analytics, around more of a population focus in care delivery, especially in some of the more integrated integrated or coordinated systems and those moving into payment reforms overall. So can that be paired in some way with, maybe some way more with Disarm in a way that sort of, I know Disarm has some of these elements in it already around attention to stewardship programs and the like. Is that something that could be paired together for two reasons? One is it really shows how Disarm is not just more fee-for-service payment, but in line with trends that are happening and that everybody agrees from a public health standpoint are fundamentally important in this country and in addressing AMR. And the second is, as you heard from the last panel, well-designed systems may be able to reduce net cost related to inappropriate antibiotic use, related to complications associated with serious infections that don't get treated quickly and appropriately with a new antibiotic or an old one. It seems like there's a potential match there, and I appreciate anyone's thoughts about maybe that as a lever to add to the Disarm momentum.
I'll maybe take a shot at this. Mark, I think it's a great idea. I think the literature, the research has shown that there is great benefit in stewardship, both from a quality of healthcare standpoint, but also a cost and spending standpoint too. I know IDSA and others can probably cite multiple volumes of data and literature that can do it. The trick has always been, how do we take that potential and implement it into the system of Medicare payments and the antiquated rules that they use? And you know, Mark, the technology and the way the technology is advanced, I think, does open up that opportunity to revisit this issue and see if we can't identify policy ways to deliver savings, and then take some of those savings and spend them back on the drug development. So I think it's a great idea and something we should explore.
So, Vance, where's Neil Clancy? Is he at Pittsburgh? Cornelius Clancy, yeah. So he's done some studies lately about the size of the CRE market in the U.S., and he's published a couple of these, another one just a couple months ago. And basically, the CRE market size in the U.S. is sufficient for about one drug to do well. But last time I counted, we have 6 and 7, depending on how you count, new drugs that could target CRE. So that's a real problem, right? How do you split one reasonable-sized market across 6 or 7 drugs? Part of the problem is, as identified in Neil's article, is the fact that these drugs are all hospital drugs. They're inside the DRG. It's a complete DRG buster. And he identifies clearly in these articles the fact that the same data that Alan Carr has been saying for some time, that we're still using in American hospitals, colistin and other polymyxins, when clearly the safer, better course is one of these new drugs. And even despite
Safer, better,
the fact,
but not cheaper.
But not cheaper, and despite the fact that that it's first-line treatment on the guidelines at the hospitals, they're still using the other drugs. So that's a real issue, and that's my motivation for doing something like Disarm or the IPPS 2021. But then you have, on top of that, just loads of clever people at the CDC and all sorts of good people at every hospital, and their goal is to actually reduce CRE incidence, which is a beautiful thing. Don't get me wrong. And if they're successful, that market, which I just said is sufficient for maybe one drug, split across 7, is suddenly going to become half that size. If the CDC hits its targets, it's going to go down. We celebrate that, but it then undermines the whole innovation equation. It actually, on the model, would require a bigger market entry reward if we get what we want, which is great infection prevention and control.
Yeah. Well, I hope, so when you come back and redo your model in another 5 years, I hope that number has gone up because we are doing a better job at infection prevention. Right. Okay. All right, 2 years. But that gets to my next point, which is that does suggest we're on a trend where at least preparing for, if not taking steps towards getting some additional payments in, more like a market entry reward, something that's not tied to volume of sales, is going to be needed as these other policies around AMR progress, which I think they will. And I want to get to subscriptions in a minute, but we also talked earlier this morning in passing about some steps that BARDA has taken, so a number on the push side, but more recently, I mentioned Paratech, that contract with some sort of milestone deliverables that are more at these late stages, Kevin, like you were talking about being so important. BioShield has been used not in this area, but arguably at least, this is a national security issue. Are there more steps that BARDA could take, not as a whole solution, but as a piece of filling in this gap and starting to move us away from a volume focus to more of an outcome and value-based market entry reward focus?
So just for framing, all the details about the Paratech contract are publicly available. I'm looking at my BARDA friends. That was a Project BioShield contract. Yes, they're shaking yes. The Paratech contract, Project BioShield, a lot of the funding for it is to pay for post-approval studies. So post-approval, this is really great news, as well as contributions to the Strategic National Stockpile for the drug. It's anthrax indication was the reason why it's being funded. And it's if they hit all their targets, it's multiple hundreds of millions of dollars. You can go look at the details. So you could think of this contract as as a model for the type of covering of post-approval cost, and also ensuring that the U.S. government and the taxpayers have access to a drug because it's sitting in the national stockpile. It's a very interesting agreement, and I found it myself quite encouraging that there was that sum of money going towards post-approval plus stockpile. But
I think it's a kind of interesting point Kevin makes. I think when we talk about what BARDA have been doing and kind of the idea of the kind of the national security ethos and the stockpiling, I think that really kind of embodies actually some of the valuation prospects that Nick's work at NICE and other work in Europe has been trying to kind of quantify and define. The idea of the availability of a drug really being the important thing, that there should be a positive value definition for governments, for health systems. And I think for me, the trying to kind of move intellectually and practically kind of move along the notion that really we should be positively defining the value of antibiotics in that way, for me, that feels like the more kind of positive path to go down than trying to go down the kind of pathway of identifying cost savings from antibiotic stewardship as being the kind of the panacea here. I think we shouldn't shy away from the fact that the ultimate problem here is that we have too little money going into the antibiotic space. So it's always going to be more sustainable to make the case positively about the value of antibiotics, about why health systems should be contributing and should be paying more for these kind of most valuable of drugs, rather than trying to kind of find our way around the kind of cost saving, spend to save type proposition. Because inevitably, if you can find a saving from good stewardship, that's a saving that's going to accrue, that's going to be kind of go somewhere else in the hospital budget. It's not going to find its way back into the kind of the R&D or procurement space. It's better to make that really kind of positive value case, whether that be in the US or in kind of HTA type systems.
All right, I want to come back to the value case in a second. Robert, you look like you had something to say.
Yeah, it's maybe just more of amusing, but to Kevin's point, I'm really interested in the extent to which the Paratech model might almost be replicable, for future problems and to encourage future investment. I think to Kevin's point, it really is trying to solve commercialization issues, and maybe with resource efficiently and with new authorities, they might be able to turn this around.
Yeah, this was done with current authorities, maybe additional appropriations or the like, but I do think it would help if those kinds of steps, again, away from fee-for-service and towards value could be reinforced in our regular payment system, and that brings us to the subscription models. So there are several countries we heard about that are starting to go down this road. A great presentation on the NHS, the NICE work, and intending to work with NHS England that we heard today, and as you heard from that panel as well, other countries, Norway, Australia, maybe Germany, others moving in the same direction. And this is an area where, Robert, to your point about sort of countries are doing it individually, but I think the sharing that's taking place and the collaboration that's taking place, we're certainly participating in this with our work on subscription models here. That parallelism is hopefully grounds for the future. In the U.S., we do think, as our recent proposal shows, we have a health affairs piece coming out on this in the next few days, something like that. We think a lot of this can be done under current payment reform authority, where CMS has not yet taken the next step beyond its NTAP payments and moving these kinds of models into something like a CMMI framework. This does mean we need to do a better job of measuring key dimensions of value, especially the key dimensions, as Jeremy was emphasizing, that go beyond what a particular hospital or even a health system can capture in terms of better outcomes for its individual patients and cost savings from reduced infections. So would appreciate any thoughts about this subscription or licensing or other direction of, or other, whatever you want to call it, this direction of reform towards paying at a population level and trying to incorporate additional dimensions of value into payments, both here in the U.S. And abroad. It seems like things are going in that direction, probably too slow for Kevin's next 2-year update. How can we accelerate this?
Mark, it's a great question. First off, commendations for really pursuing this model, and look forward to seeing it going forward. I think 3 considerations here. First off, as everyone knows, the Medicare system and the system in general is on a value trajectory, right? We are trying to identify how to extract greater value out of the things that we've done yesterday, i.e. improvements. Those improvements are both potentially quality of care and cost. Second thing is, as you think about the value of antibiotics, cost, i.e. the spending on more antibiotics, will not necessarily directly, immediately create savings. But the way to frame the value conversation within Medicare is to imagine the system without antibiotics. To imagine what a DRG looks like if you can't perform a surgery. And in all the ways that we can start quantifying, we might start to create some quantifiable numbers for the administration. But even beyond that, though, the question becomes, and one consideration that CMS is going to have to address is, what is the value to us in doing this? And this is where the subscription model really can play a strong role. I think, identifying the types of drugs and the type of treatments and the way in which those are prescribed under those payment systems, as we've discussed through stewardship and other things, can be huge. Number 2, identifying how providers and payment relates to those drugs is key. We've talked about IPPS on the payment side, but on the provider side, thinking about it from a standpoint of changing the metrics around fee-for-service of these drugs, and maybe even diagnostics too, really begins to help fund and demonstrate the value in the system. And then if supported by good stewardship and other diagnostic pieces, really do think that the stewardship or the subscription model can be a centerpiece for how we begin to truly demonstrate the value of antibiotics to the system, Mark.
Great, thank you. Yeah, Brenda.
Yeah, I was just going to add, this is one of the things that I've heard today that patients can really help define this value. There's obviously different layers and different kind of scopes of value, but to understand what's important to them, and not just that they're surviving, but how are they surviving, and just to build in so much more context about how the quality of their life and the real impacts on patients. So I think this is one of the many spots where patients can really be helpful in defining value.
Great, thank you. Kevin?
So I think it's fair to say that health technology assessment organizations like NICE have historically taken the number that like the drug companies have offered and have tried to find good HTA ways to argue for a lower number, right? The purpose has been to protect the public purse by lowering the number to something that's more reasonable for the whole society. For antibiotics, what's great about what NICE is doing right now is that they're actually trying to build a case for paying more, okay? Which is because we all understand that that's necessary. So, whatever the subscription model is, this is not a traditional Medicare value-based payment neutral to the budget or better. We actually need to pay more, or else we're going nowhere here. And the second point is that the only, a problem I have about the subscription model, if I don't pay for Netflix, I just don't get the movie or whatever it is I want to see. But if a country or a hospital doesn't pay the subscription fee, are we really gonna not give them the antibiotic? So what do we do with the non-subscriber? Is an open question.
Good question. By the way, that question often comes up in healthcare. It's like withholding the treatment.
Mark, maybe just to drill down on Kevin's question. Kevin, is the question, should every country adopt the subscription model, or is the question that the subscription model might be one way to fund, let's say, AMR solutions that a country can consider?
Especially as more attention to these dimensions of value that sounds like we want to try to get every country to pay more attention to. Yeah. Okay. So I've got one more question, and everybody here should be ready for piling on with their comments and questions. So one other topic that came up, Jeremy, I think you brought it up in this session, but it came up earlier too, was and Brenda was ways to engage both the investor community and maybe more of the pharmaceutical, especially the experienced pharmaceutical manufacturing and distribution community in helping with this problem. And Kevin, again, we're not going to try to go back to your slide, but if you don't mind my sharing a number that was in that small print, you had divided the assumptions about costs of development at each phase into different categories with preclinical, phase 1 to 3, regulatory submission, and post-launch. And the post-launch number, $350,000, I think is larger. 350, sorry, I forgot. We're in healthcare, so it should be billion, but 350 million, the 350 million in post-launch costs is bigger than the cost estimated in all of the other phases of development combined. And that goes to Jeremy's point about, gosh, that seems like a big number, just to paraphrase you. And so can we kind of push a little bit more on what might be done about that? That came up on our second panel too, where there's some discussion about investment and sort of aggregators. I've heard from some of there are actually large pharma perspectives here in the room about, they've got manufacturing capacity in other areas like gene therapies. There's some ideas being pursued around just building a sort of platform regulatory capacity that could be applied to a number of different gene therapies. Is something? What are the ideas or directions to bring that number down?
So I think from our perspective, I think we would see that there has been I think the kind of the post-market, the kind of that sort of $350 million figure, I think it's been a bit of a blind spot maybe in some of the earlier conversations around this topic. I think there was often a sense of getting to kind of first approval as being somehow the finishing line, and maybe, for instance, kind of the O'Neill analysis maybe didn't properly take into account.
And then you had
really
Melinta and Achaogen.
What happens beyond that? And yeah, you're right. Achaogen has really kind of put this into kind of very stark relief. The extent to which those follow-on costs for label expansion is such a kind of significant part of the overall cost envelope. I think I'd say two things about it. I think firstly, the way we would see it is that really when you see kind of such a loading of costs towards phase 3 and after first authorization, that really underlines from our point of view as a philanthropic funder that that's the type of cost that really we can't bear without it impinging very dramatically on our ability to fund the very early stage stuff where the cost of capital is astronomically high, where the risks are very, very high, and where really we see public and philanthropic capital kind of playing its most vital role. And so it's better from our perspective to try and make sure that actually how can we, rather than trying to say, okay, well, let's put the burden of that funding onto public funders, onto philanthropic funders, what are the kind of the tweaks that we can do to make sure that actually you make that an investable proposition? We should be able to raise that money from private capital. The levels of risk are sufficiently low that you should be able to kind of play with that in a way that you can't play with making the much earlier stage stuff an investable proposition. I think kind of the second point is that I think those costs don't necessarily come down dramatically, but it does underline that there are very significant challenges in terms of the scale up and in terms of what the most efficient model of business looks like. And with the best will in the world, I hope that many biotechs would agree with this, that actually it's not playing to the skills of small biotechs to be trying to do that scale of activity, and it probably doesn't result in what we need from a global perspective in terms of ending up with something which is available in global markets rather than the US and a couple of key European markets. So really, what that points to for us is saying, okay, well, what are the ways that you can somehow bring down the risk, somehow underpin the risk, so that you can A, bring private investors back in, and then B, either find a way for big pharma to bring their skills, their resources, their capacity to the table for that sort of late stage stuff, or find ways to bring together multiple assets, either on commercial terms or kind of non-traditional commercial terms, to make sure you have a basket of assets going through that post-authorization journey, through that commercialization pathway, as a bundle, rather than trying to do it as kind of a bunch of kind of struggling individual companies that don't have a track record, don't have a history in this space.
Great, thanks.
So a couple things. First of all, this is exactly the sort of input I want to critique estimates and parameters in the model. The $350 million is over 7 years, so it's $50 million a year, which is a number that came from the Achaogen folks' presentation at ASM ESMID in September of last year. That public presentation, the website is available in many places, including CARB-X, the recording of it. It's validated by, if you look at the SG&A for the small public companies that have one drug in the market, you can see what they tell the SEC their annual SG&A is, and it's in that range. Part of the issue here is that the FDA has made it easier for antibiotics to receive approval in the past decade, and so we have more antibiotics that reach the market with a relatively small number of patients in a non-inferiority trial, and there's a requirement for evidence development. Additional studies in order to differentiate their drug. That's part of these costs. And then finally, look at the Paratech contract. There's a couple $100 million in there for exactly these sorts of post-development costs, which I would assume BARDA has scrubbed thoroughly. And I don't remember the time period or the exact number on Paratech. But this is within shooting range of these types of expenses.
Yeah, by the way, I was not saying that the number was, not critiquing the number, just pointing out that is
it's a lot bigger than any
issue.
of us thought.
Yeah.
For a normal company, they would be funding this out of the sales from the drug, and they wouldn't have to go raise additional capital. Right. For these little companies, they have to go back to public markets in a very difficult moment and raise it. What Jeremy just said about scale is really important. It might be one of the least efficient ways for a single company to try to scale this up by themselves. One could imagine that big pharma can do this at a lower price, or somebody at scale could do this at a much more efficient level.
To Jeremy's point about getting the capital in, it doesn't seem, if the revenues were there, it doesn't seem that risky. Okay, we'd like to open this up to comments. We got a little bit of time before we wrap up, so additional comments, questions about the ideas we've discussed and the path forward.
Vance Fowler. I wanted to emphasize something that Brenda mentioned about, and that's about the role of the patient. Because if you think about the experience with HIV, the AIDS epidemic, and those of us who are old enough and were taking care of patients back in the bad old days, there was this group called ACT UP, and that's exactly what they did. And we need an ACT UP for antibiotics. Our patients with AMR infections don't need to just get better; they need to get bitter. And they need to lash out against politicians, because right now, the real problem that we're kind of facing against is apathy, right? People, politically, they don't really care. I mean, there are a lot of other big problems. I get that. Okay, that's fine. But and if you look at, there are a lot of things different about the HIV epidemic. For one thing, there was a market model that made sense, and economics of the drugs and yada yada, but against them, they were really confronted with a whole lot more than just apathy. There was active, these patients were ostracized actively. They were pariahs, and yet see where we are now. I had clinic yesterday morning. We have 8 or 10 drugs, one pill once a day.
Yeah.
Incredible toxicity profile. I mean, it's amazing. So so I guess what's the point? The point is, I think the role of the patients, not just the stories about which I personally have contributed my own patients for, and referred them to IDSA, and they've helped. But I think that's necessary, but not sufficient. There needs to be political organization of some form in which the patients can say, hey, wait a minute, why did I lose my leg? Why am I flopping around like a Raggedy Ann doll because somebody can't get this MRSA out of my hip? Why is that? What do you mean there's no drugs?
Let me ask,
I'll stop there.
it's a very important question. I'm glad that we got it in, but I want to maybe push the panel on the right analogy here. I mean, I lived through in my own medical practice seeing care going from just supportive care for AIDS to one pill a day, and so many other non-bacterial infectious diseases are going in that same direction. Hep C, others to come, no doubt, but not for the bacterial infections. And is ACT UP with patients who just don't feel like they're getting enough response in the system for the infections they have? Is that the model? Or the other model I hear a lot is this is the medical version of global warming, where the people who should be angry are not just the people who have infections today, but all the ones who are at risk of potentially disability or death because of this trajectory that we're on worldwide. And it is really a worldwide issue. So appreciate your thoughts on how to do this. And maybe Brenda, will see you out protesting outside the Capitol next year or something like that.
Well, Mark, I mean, to your point, one of the things that has been missing, and I really do appreciate this, during the GAIN Act, during ADAPT, during a number of issues that we really tried to generate in the past to solve this problem, what was missing was the patient voice. We oftentimes had to rely upon veterans groups, military organizations, and children's hospitals to help make the argument. But unfortunately, it's a drop in the bucket in terms of what the patient advocacy voice can do. What I find fascinating about what we just heard is that, honestly, it's the largest patient population of any issue, right? It's everybody. Everybody's a patient. But what I just heard was the formation or the creation of the first patient group focused on advocating for AMR solutions. So I'd like to thank Faster Cures for that and look forward to working with you.
Yeah, I mean, I think we can just pull lessons learned from everywhere. I don't know that it fits in one model or another, what's the best analogy, but, we're really excited to go out and talk to people and see what is the landscape today, how can we really activate and mobilize, because we do need more than just a one patient at the table kind of thing. We really need a concerted, driven, focused effort to get that.
So many of you will know, but Wellcome Trust obviously is part of our mission, kind of public engagement with science and public kind of support and understanding of science is a tremendously important part of our mission. And last year we did a major piece of work around the reframing of antibiotic resistance, and that was the biggest piece of communications research undertaken in this space to date. We talked to about 12,000 people in 7 countries around the world about their understanding of AMR and kind of did some systematic message testing to understand exactly kind of how to push people's buttons, how to get people to understand the issue and engage with it in a much more persuasive way. And that kind of really showed us that there is it's so much more powerful to talk about it in terms of the human impact, the patient impact, the effect in the here and now, rather than talking about it in kind of abstract 10 million lives in 2050, those sorts of things that make it appear kind of far off. It reduces the salience of the issue, all of those things, which isn't necessarily rocket science, but it was so kind of powerful to see it really in kind of quantified terms, just how different the impact was when you could tell a patient story. The other thing that came out from that was that really the UK media interest in the issue is much greater than any of the other markets that we looked at. The kind of the volume of coverage in the UK is peculiar. And I think part of that is down to Sally Davies, who has been a kind of an absolute force of nature in this and has done kind of more globally and domestically than many people to drive this issue up the agenda. But I think part of it is also that there is kind of this lingering thing in the UK national psyche around the MRSA crisis in the early 2000s, and really that was one of the most kind of pronounced crises in the NHS, which many of you will know is kind of our national religion. And what that really showed was that came at a time when suddenly there was a tipping point, and patients started to realise they were getting this thing, this four-letter acronym they never understood or heard about before, but it was avoidable, it was unnecessary, and it was killing people in numbers that was unacceptable. And that created a kind of a media storm and created patient stories, and that created an immediate political pressure. And that was what kind of really mobilized significant spending, significant kind of administrative pressure on the NHS to deal with these things. And I think that's a kind of good case study of actually what can happen where you do have the patient outrage on an issue like this. It's not impossible to get the patient outrage on antibiotic resistance. It's just making sure that people are aware of what they're affected by, aware of the fact it shouldn't be acceptable, and aware of the fact that they should be calling for politicians, health system stewards, industry to be taking action in a kind of coherent way.
Yeah, really compelling. Okay, we got time for 2 more comments. I'm not sure who was first. You guys are so polite.
Hi, Lou Borio from Inquitel. My question is
okay, can you speak right in the microphone? Sorry.
To Kevin. Okay. And I'm sure I'm wrong about this, but I really appreciate some clarification. And I'm really happy to hear that we all agree that less CRE infections are a good thing. But then you're going to say that if you have less infections, CRE infections, that you reduce the market size for this special miracle drug product that is going to cure the CRE. And I think that's true if you have a fixed price for this miracle cure. But the fact is that the market, technically, theoretically, I guess, the company could charge according to the value of this miracle cure. So if there are less patients, you could charge more money because you have a very special cure. So why is this not happening? What component of the system is fixing the price or restricting the ability to recoup the value of that miracle drug, given the system we have today where there is really in theory, no fixed price setting for a particular drug? Thank you.
So thank you, Lou, for the question. It's hard to know, exactly why they're not able to charge, say, $5,000 a day for a CRE drug. One is the way that the DRG is structured, but that doesn't answer the question, because if there was an absolutely clear clinical answer, this patient clearly would do better on this drug than the older drug, most clinicians would still do the right thing, even if the CFO came down on them with a rain of bricks. But we have the combination of the non-inferiority studies and the lack of diagnostic certainty at the moment in which that clinician is making that decision, plus the incredible financial pressure. The other thing I'll say about CRE is that the U.S. cases that require hospitalization are about 1% to 2% of the global total. And the vast majority of those are in really poor countries that couldn't possibly afford this high price. So my major point was that, we need, the CRE reductions would be great in the U.S., but it will just make the question harder on how do we appropriately pay for that innovation and make it available to the patients who need it. I don't know if I answered it enough, or if you want to pin me to the wall some more. Okay.
So this is maybe part 2 to the same question, and I think would invite answers from the whole panel, but sort of touching on what you were just noting, Kevin, is what about the global market? When we talk about these issues, we note the challenges to the DRG, we note the challenges to the unique healthcare financing and structures of the United States and the UK or whatever it is. But ultimately, when we're talking about the burden of CRE, those account for the vast minority of the global burden of these. If we had a true understanding, which I think we need, of the global burden and the country by country burden of things like CRE, we could easily, the global demand for those things could easily, and the global market could easily compensate for 6 CRE drugs. There are enough cases around the world to be able to do that, but what do you think is lacking there, and do you think that having a better understanding of country-by-country burden of some of these things could actually help, recognizing that there are certainly great disparities in income, but if we have 1 million patients on a CRE drug in India or another part of the world, you don't have to charge as much to recoup all of the costs that went into it?
Yeah, I mean, it's a great question. I mean, like I said, 98% is outside the U.S. We suspect, but don't know for sure how many are in India, but it's probably a huge number. Would you agree? Yes. And so, the idea of, getting these companies to have a lower priced $500, $300 a day version of their drugs in India sounds like a good thing. From an epi perspective, it'd be nice if we were appropriately treating and preventing transmission. It'd be great for the world. But think of the 56 people on the Achaeogen, medical affairs and marketing team trying to cover a couple hundred U.S. hospitals. I can assure you that it wasn't even in their thought to think about opening up a New Delhi office or a Bangalore office. So it goes back to Jeremy's comment on scale.
Yeah. Well, there are some larger pharmaceutical companies who are trying to address this problem with access programs in less developed countries.
And who bought plasmamycin?
Yeah.
An Indian generic company. So, there may be to be determined on what's coming next from CIPLA.
Interesting.
I don't know.
Okay, we're going to try to get in 2 more comments, questions. If we can go quickly, please go ahead.
Great. Mike Dudley, QPEX Biopharma. We're still fighting the good fight, trying to come up with new drugs as well. I think a couple of things that may be helpful in looking at this is looking at how the operating models for companies have performed and existed for orphan drugs. Not necessarily, I'm not speaking about orphan drugs from the regulatory perspective or any of that, but just simply how companies operate in terms of drugs for orphan indications. So examples of that, if you actually, and there's been some nice literature recently looking at this at the orphan drug program since 1983. And if you look at the number of patients and you look at the cost per course of therapy, it actually lines up very, very well of the numbers of patients with AMR, and it starts to talk about different numbers that you need. The number of patients, like in terms of a cost, in terms of caring for those patients, is actually a very small proportion of the actual total healthcare cost when you look at drugs as well.
And the price per treatment course is?
Yeah, cost for treatment course. Now, you would say that some of these are chronic diseases, but if you annualize that even just for a course of a therapy of a patient who has a CRE infection, because assuming they have it only once, it comes out to be about the same number of patients that are managed as part of that. So that may be helpful and gets us closer to those kinds of numbers, because when we were getting ready to launch one of the CRE drugs when I was still at the medicines company before I went to Melinta, we looked at what you would need to do that. And your course of therapy for a CRE infection would be about $30,000 per course to cover all the costs and overhead as part of that. Problem is there's no way to put that onto the backs of hospitals to be able to pay for it. So I think maybe looking about how orphan drugs and the willingness of society to pay for that may be helpful in terms of extracting the value.
Any comments to add to that? Because that seems like a different and interesting way of putting the earlier question about, well, why aren't companies charging a higher price?
I will say that it's a good argument. I think the Congress did look at that in 2007, and we're hoping, I think, to get AMR to qualify as an orphan population for the purposes of incentives. And I think the administration didn't concur with that a little bit, but it's a good argument. It really is. It's even though the size of the population is so huge, the treatment courses, things like that, almost mirror a much smaller population of patients. That's a great point.
Kevin, did you want to add something?
To my knowledge, no antibiotic has had orphan drug designation at first approval. It's my understanding, and FDA people in the room can correct me, it's because the drug, even if it's indicated for CRE, can treat lots of other people with bacterial infection, and it exceeds the $200,000 number. But that's the second way to get into the Orphan Drug Act. The first one is that you can show that it's economically infeasible, which antibiotics, we've demonstrated that ad nauseum for a decade now. But when I've mentioned that first category, which everyone uses the second, not the first, Venture capitalists have said, wait, you want me to admit publicly that my drug can't make money? So I think currently, if someone who's willing to bite the bullet, even without changes in legislation, could get an antibiotic in through the orphan, a narrow spectrum antibiotic in through the Orphan Drug Act.
Yeah, I just want to clarify, though, I'm really not advocating for it to be into the Orphan Drug Act or get the regulatory or any exclusivity provisions. I'm really just thinking about the operating models and economically about how we think about paying for orphan drugs now. Because if you actually look at how many drugs are still protected by exclusivity but are still on the market, it's a very small portion of those drugs that are actually protected by the exclusivity. They're on the market just simply because they can make money, and patients want them and need them.
Yeah.
Maybe just one thing on this too. It's the Open Act. Incentives for small populations have currently gone dark a little bit. I think there are efforts to maybe identify a new type of incentive that is not exclusivity based. So to your point, that conversation may be an opportunity to raise this AMR issue as well.
Yeah, interesting. Okay, last comment, please.
Hi, Kathy Talkington with the Pew Charitable Trust. Just a comment more than a question at this point. Wanted to mention that we have a group in the conversation that's been going on around advocates and the voice. We have a group called Stand Up to Superbugs. And so for those of you who are interested, we would love to coordinate that effort. As has been mentioned today, it's not easy to find those voices. We spend all year finding about 40 voices that we bring to Capitol Hill to talk about the problem and to try to advocate for more funding and legislation. So just wanted to make that point because I would love to coordinate with others that are interested. Thanks.
Thanks very much. I want to thank Pew as well for all of their, Alan's here too. I thank Pew for all their leadership and engagement on this topic as well, and probably a good, I'll take that as ending on a reasonably positive tone on this very challenging set of issues. So we're a little bit over time. I want to thank all of our panelists for being here today, in particular this last panel for helping us pull all of this together and leave the room at least a little bit, if not optimistic about the future, realistic that there are some important next steps that we can take building on recent progress and activities. Thanks to the Wellcome Trust for their support for our work, including here today. And for those of you who are here, we will be continuing to do events, activities. I mentioned that paper that should be coming out in just a few days related to the subscription model. So please stay tuned with us. And a last special thanks to our team at Duke-Margolis, Nick Harrison, Elizabeth Murphy, who didn't have to, everybody was pretty well behaved on the timing, right? David Ridley, who's done a tremendous amount of work on these types of models, Sarah Sapsiri, and especially Monica Schneider for all of their efforts to bring this together. Thank you all very much, and I look forward to continuing to work with you on this very important public health threat. Thank you all, and have a good day.